acute skin and pulmonary toxicity with and without bolus in adjuvant post-mastectomy radiotherapy. The materials and methods. My study is a randomized interventional comparative analytical study. Study population histopathologically proven and post-operative, that is modified radical mastectomy breast cancer patients attending Department of Radiation Oncology at SMS Medical College and hospitals. The cases were randomly distributed among two groups, that is my study arm, that is post-operative patients who were treated with IGRT technique, that is 50 gray in 25 fraction to the chest wall and skin using a gel bolus of 5 mm. Control arm, that is post-operative patients who were treated with IGRT 50 gray in 25 fraction without bolus. Inclusion criteria: patients with invasive breast cancer who underwent modified radical mastectomy and who are candidate for adjuvant RT. Age have taken from 18 to 70 years. Female, ECOG status is 0 to 2. Exclusion criteria: locoregionally recurrent or metastatic tumors, cardiac and pulmonary comorbidities, any history of connective tissue disorders, immunocompromised patients, pregnant and lactating women, history of previous radiation to the thorax. The present study enrolled 70 post-mastectomy breast cancer patients equally divided into two treatment arms with and without bolus application during the adjuvant radiotherapy. The socio-demographic and clinical parameters such as age, cancer stage, hormonal receptor status, HER2 new receptor status, prior chemotherapy exposure, and tumor laterality were analyzed to ensure proper group comparability. All post-operative breast cancer cases were treated by IGRT technique on linear accelerators. Treatment was delivered in supine position with proper immobilization. A 6 MV photon beam was used for all patients. Patient with arm A received RT with a gel bolus of 5 mm thickness on chest wall, and arm B received RT to chest wall without bolus. Results. The results underscore a clear dosimetric benefit of bolus use in terms of improved peripheral target coverage, that is PTV planning target volume of D95%, while maintaining safe radiation level to critical structures like heart, lungs, and contralateral breast. The bolus probes especially valuable in achieving optimal chest wall surface dosing, important in patients with skin involvement or high risk of superficial recurrence. A statistically significant divergence emerged by 5th week, where grade 3 and grade 4 skin reactions were substantially more common in the arm A, that is study arm, that is p value is 0.008. Specifically, 13% experienced grade 3 and grade 4 toxicity in the arm A, in compared to 7 and 1 respectively in the arm B. The study confirmed that pulmonary function remains well preserved with bolus use, and lung dose parameters stay within safe threshold, aligning with global literature. Thus, bolus application does not pose any added risk of radiation pneumonitis or long-term respiratory dysfunction. Arm A shows a significantly higher mean PTV, that is planning target volume of D95%, that is 48.63 gray compared to 47.82 gray in the arm B, that is my control arm, with a p value of 0.006, indicating a statistically significant improvement in dose coverage. The standard deviation was also reasonably tight in both the groups. This result supports the dosimetric advantage of using a bolus in achieving better peripheral target volume coverage, which is essential for effective local control and post-mastectomy. This is skin reaction. We have analyzed skin reaction in week 1, 2, 3 and 4. On 5th week, a significant difference emerged, grade 3 and grade 4 toxicity in arm A and arm B. In comparison to arm B, there is this result validated the concern that bolus use enhanced skin dose and has escalated the acute skin toxicity, but it is manageable. Pulmonary function test. We analyzed the forced expiratory volume at 1 minute, that is in 6 weeks. The maximum toxicity seen in without bolus, that is control arm, but less toxicity in comparison to in less toxicity seen in with bolus. Then however, both groups nearly returned to baseline by 12 weeks and none of the difference were statistically significant. The data suggests that bolus use did not cause long-term pulmonary impairment and may have helped preserve lung function slightly better during peak toxicity. The finding imply that bolus use does not adversely affect respiratory function. Summary: the application of bolus in post-mastectomy radiotherapy offers a clear dosimetric advantage in terms of improved PTV coverage without significantly increasing radiation exposure to organ at risk or inducing long-term pulmonary compromise. While it does lead to higher grade skin toxicity in the 5th week of treatment, this effect appears manageable and should be weighed against the benefit of enhanced superficial dose conformity. Based on the present finding, the judicious use of bolus remains a justified and potentially beneficial practice in the context of post-mastectomy chest wall irradiation, particularly in patients with high-risk features where optimal surface dose coverage is critical for local control. Thank you.
How you assess the pulmonary toxicity? What criteria you use? Clinical or any radiological image?
So clinically and radiological image also, we see the pneumonitis, post radiotherapy pneumonitis with on X-ray.
On X-ray. What is the time interval after the radiation?
Sir, we have seen the after 2 weeks. After 2 weeks, patient clinical features changes, but it peaks at the 6th week. On treatment, supportive management, steroids, and patient symptom pneumonitis and broad spectrum antibiotic symptoms resolves, but and it comes to baseline at 12 weeks of treatments.
X-rays may take time. PFT also you do monitor PFT during the treatment period?
Sir, we also see the pulmonary function test, that is FEV1 with ABC. Yes.
Did you have any prophylactic use for the skin toxicity?
Ma'am?
Did you use the prophylactic like this moisturizing cream or something like to reduce the skin toxicity?
So during RT, there is no indication of any emollients over the skin because it decreases the dose delivery to the critical organ, the target organ. So after RT, after RT, we may use some emollients for epilations or some minor grade 1, grade 2 skin toxicity according to RTOG guidelines. But in grade 5, we have to stop 1 to 2 days of RT for recovery of skin.
Thank you.
Thank you.
Next we have Dr. Suraj Khandelwal. He is going to present his observational study to assess radiation-induced esophagitis in CA breast patients.
Good morning, sir. My topic for today's presentation: an observational study to assess radiation-induced esophagitis in carcinoma breast patient receiving adjuvant radiotherapy. Background: radiotherapy is an essential treatment modality in the overall management of almost all breast cancer patients, from early stage disease to locally advanced and metastatic cases, which effectively reduce breast cancer recurrence, morbidity and mortality. As anatomical, the esophagus is situated adjacent to the regional node, so there is potential to expose greater volume of the esophagus when implanting these guidelines. Therefore, regional nodal irradiation may increase the risk of the greater frequency and increase severity of the acute esophagitis during treatment. Radiation esophagitis causes various clinical symptoms, that is odonophagia, substernal pain and dysphagia, and having to modify their diet, which adversely affect the quality of life. Material and methods: patient selection, conjugative patient diagnosed with the breast cancer treated with the RT at SMS Jaipur to the SCF after the breast conservative surgery or mastectomy were included in the single-arm prospective observational study. Inclusion criteria incorporate the patient is more than 18 years, willingness to participate in the study and availability for once in weekly review for the duration of RT. Patient must receive a blended dose of the 40 gray in 15 fraction to the breast or chest wall and the supraclavicular fossa. It also include IMFC and axillary nodal irradiation are also allowed. Exclusion criteria included suspected or confirmed pregnancy, previous RT to the ipsilateral breast, a history of the collagen vascular diseases, or any other condition in which RT is contraindicated. Before treatment, written informed consent was taken from all the patient. Esophagitis was graded by using a modified radiation therapy oncology group RTOG acute morbidity scoring scale. Once in week throughout the treatment and until all the symptoms of the esophagitis has subsided after treatment completion. Result. The study was conducted on the 25 consecutive patient. The average age of the patient was 44 plus minus 9.19 year. With the left versus right sided breast cancer, 14 out of 25 versus 11 out of 25 respectively. Almost all patient, 21 out of 25, 96% had chemotherapy before radiotherapy. Half of the patient, 13 out of 25, 55% received radiotherapy to the breast or chest wall and the SCF. Only with an average mean dose to the esophagus was 10.65 plus minus 2.69 gray as mentioned. Toxicity, 12 patients shows grade 1 toxicity, mild esophagitis, and 13 patient, 52% shows grade 2 esophagitis, moderate esophagitis. No patient were observed in the grade 3 toxicity, severe esophagitis. Commencement of the grade 2 toxicity was in the second week of the treatment and reached its peak in the week after completion of the treatment. It was observed at 10 to 14 gray, while 1 gray increment and overall mean dose of the esophagus of more than 12 gray was associated with the increased frequency of the grade 2 esophagitis in 7 out of 11, 63.63% versus less than 4.5 centimeter of the esophagus in the treatment field, 6 out of 9, 66.66% versus 7 out of 16, 43.75% respectively. P equal to 0.04. In the multivariate analysis, the odd ratio of the developing grade 2 esophagitis with a mean dose to the esophagus more than 12 gray compared to the less than 12 gray was 2.33. 95% confidence interval equal to 1.1 to 3.89, P equal to 0.02. The odd ratio for developing grade 2 esophagitis with more than 4.5 centimeter of the esophagus in comparison to the less than 4.5 centimeter involved was 2.75. 95% confidence interval equal to 1.23 to 5.18, P equal to 0.04. Both of these factors were observed to the independent predictors of the grade 2 esophagitis. On comparing the side of the treatment, left versus right breast, more patient was reported on the left side treatment, but result was not statistically significant. P equal to 0.93. The mean volume of the esophagus for patient was 18.42 plus minus 6.43 cc. And mean volume of the esophagus in the PTV SCF was 1.30 plus minus 0.97 cc. Internal mammary chain was included in the treatment volume of the all patient. This is the RTOG for acute esophagitis, grade 1 no dysphagia or odonophagia, grade 2 mild dysphagia, grade 3 moderate, grade 2 moderate dysphagia, grade 3 severe dysphagia or odonophagia with dehydration or weight loss of greater than 15% from the treatment baseline requiring NG tube feeding, IV fluid or hyperinflammation, hyperelimination. Grade 4 complete obstruction, ulceration, perforation or fistula. This is the clinical data of the breast cancer patient undergoing radiation therapy in the prescribed dose of 40 gray, 15 fraction, total N 25. Age in the year, mean 43.48, SD 9.19, mean maximum median 31, 62, 44 respectively. Total length of the esophagus in the PTV, mean 3.55, SD 1.78, mean maximum median 0, 6.09, 3.73 respectively. Mean dose, mean 10.65, SD 2.6, mean maximum median 4, 15.6, 10.87 respectively. Maximum dose, mean 14.1.22, SD 2.62, mean maximum median 30.3, 44.7, 41.4. Total volume of the esophagus, mean 18.4, SD 6.3, mean maximum median 11.3, 34.4, 16.7. Volume of the esophagus in the PTV SCF, mean 1.30, SD 0.97, mean maximum median 0.0, 3.4, 1.1 respectively. This is the comparison of the mean dose, length of the esophagus and treatment side. Esophagus mean dose less than 12 gray, equal to or more than 12 gray, less than grade 1 or grade 2. Esophagitis in less than 12, 8 grade 1 or 6 grade 2, more than 12, 4 grade 1 or grade 2, 7 respectively. P value 0.024. Length of the esophagus in the PTV SCF less than 4.5 centimeter, grade 1 9, grade 2 7, more than 4.5 centimeter, equal to 4.5 centimeter, it is grade 1 3, grade 2 6, and P value equal to 0.049. Laterality, left or right, grade 1 7 and grade 2 7, for right side 5 or 6 respectively, and p equal to 0.9345. Discussion: it was analyzed that mean threshold of the more than or equal to 12 gray to the esophagus lead to the significantly higher frequency of the esophagitis in breast cancer patient undergoing radiotherapy. Also observed that if the length of the esophagus involved in the treatment field was more than equal to 4.5 centimeter, it increased the risk of the onset of the grade 2 esophagitis. According to the CTCAE, is at least grade 2 in severity. Literature regarding incidence of the symptoms of the grade 2 esophagitis from previous studies in the patient ranging from 6.2 to 44.8. This variation may be due to study type and esophagitis grading scale. Prospective studies tend to capture more radiation esophagitis. The incidence of the grade 2 esophagitis was 52% in present prospective studies, which was supported by the result of the study conducted by the Bang et al. In present study, the esophagitis commenced at second week, peaked in last week of the radiotherapy, and symptoms lasted for 3 weeks after completion of radiotherapy. In conclusion, the esophageal dosimetric parameter was evaluated in the study with hypofractionated dose, and mean dose was within the value of the most published studies. Prospective clinical studies with the large sample size were required to evaluate mean esophageal dose and the grade acute esophagitis. Routine contouring of the esophagus and planning accordingly may decrease the incidence of the acute esophageal toxicity and esophageal dose.
The sample size is, I think, 25. How you decided it? It's, I think, too small to.
Sir, it is decided by the PSM department. We go to the PSM department related to our study, and they are decided sample size 25.
Thank you for the presentation. How long did it take to recover from those esophagitis in the patients?
Ma'am, usually we see in our institute, it's up to the grade 2 esophagitis. Grade 3, less than 1% patients are present. In grade 2 esophagitis, we usually modify their diet from solid to the liquid, and from liquid to the, if patient is difficult in the swallowing, we insert trials tube insertion. After that, we applied lignocaine. For more severity, we give patient to the antacids like pantoprazole, omeprazole. If there is more, then we start steroid dexamethasone. It will subside after completion of the RT.
Thank you. Thank you very much for the presentation. It's all. Okay. The next presenter will be Dr. Arti Kumawat. Please come up to the podium, start your presentation.
Good morning all, I'm Dr. Arti Kumawat, Junior Resident in the Department of Radiation Oncology at JLN Medical College and Hospital, Ajmer. So the topic of my study is prospective evaluation of early subclinical cardiac dysfunction in breast cancer patients receiving adjuvant radiotherapy with or without concurrent trastuzumab, including both left and right-sided tumors using serial echocardiography, a 2D planning with Cobalt-60. So breast cancer is the most common malignancy among women worldwide, and adjuvant radiotherapy is the cornerstone of treatment for breast cancer. Despite its therapeutic benefits, RT-related cardiotoxicity remains a concern, especially in left-sided cancers. HER2-positive breast cancers, which constitute approximately 20 to 25% of cases, are aggressive in nature but benefit significantly from trastuzumab. However, trastuzumab is associated with cardiotoxicity, particularly left ventricular ejection fraction decline, which may be exacerbated by concurrent RT. Previous trials like Herceptin adjuvant trial, NSA-BP B31 and 9831 demonstrated trastuzumab's efficacy, but data on concurrent use with RT, especially 2D Cobalt-60 based therapy, are limited. Right-sided breast cancers considered lower risk for radiation-induced cardiac injury also lack comprehensive evaluation. Echocardiography is a reliable, non-invasive tool for detecting subclinical cardiac changes during treatment. So the The aim of our study is to prospectively evaluate early subclinical cardiac dysfunction in breast cancer patients receiving adjuvant RT with 2D cobalt-60, planning with or without concurrent trastuzumab, including both left and right-sided tumors using serial echo. Materials and methods. The study population included all breast cancer patients scheduled for adjuvant RT using 2D cobalt-60. The study duration was from January 24 to September 25. Inclusion criteria: patients with HER2 positive disease, defined as an IHC score of 3+ or FISH positive, were eligible for trastuzumab therapy in the study arm. A normal baseline LVF more than or equal to 50% was required before the initiation of trastuzumab and RT. Study parameters included baseline and post-RT 2D echocardiography to assess cardiac function, and LVF was documented at both time points. The study protocol received ethical approval from the Institutional Ethics Committee of Jalen Medical College, Ajmer. Treatment protocol. For adjuvant treatment, standard chemotherapy protocols were followed, and trastuzumab was given for HER2 positive cases. And treatment was withheld if at any point of time LVF was less than 50%, or there was a more than or equal to 10% decline from baseline, or heart failure symptoms appeared. And re-evaluation was done at 4 weeks, and trastuzumab was discontinued if LVF failed to recover or CHF was confirmed. Radiotherapy technique: 2D cobalt-60 based radiotherapy to breast or chest wall with regional nodal irradiation. A total dose of 50 gray in 25 fractions over 5 weeks was given to whole breast or chest wall. An additional boost of 10 gray in 5 fractions using electron beam was given to tumor bed for breast conserving surgery patients. Outcome assessment. Cardiac events were assessed based on changes in LVF from baseline as per CTCAE criteria. Grade 1 is less than 10% drop from baseline. Grade 2 is either resting ejection fraction between 50 to 40% or 10 to 19% drop from baseline. Grade 3 is either resting ejection fraction between 39 to 20% or more than or equal to 20% drop from baseline. Grade 4 is a resting ejection fraction of less than 20%. Patients were categorized into 4 predefined groups. These are left-sided RT with and without trastuzumab, right-sided RT with and without trastuzumab. Statistical analysis was performed using chi-square test of Fisher's exact test for categorical variables and Mann-Whitney U test for continuous variables. A p-value of less than 0.05 was considered statistically significant. Results: baseline patient demographics and clinical characteristics. So median age and BMI were comparable between all the groups with no significant p-values. Comorbidities like hypertension and DM were infrequent and evenly distributed. No significant differences were observed in the histology type, tumor stage, nodal stage, hormonal status, and HER2 new status. Suggesting well-balanced cohorts and ensuring that subsequent cardiac outcomes were not biased by the demographics or health differences. Results: treatment characteristics. For adjuvant chemotherapy regimens, mostly anthracycline and taxane based were used uniformly across all the groups. Cumulative doses of anthracyclines, taxanes, and cumulative dose of trastuzumab in the concurrent trastuzumab group showed no significant differences, suggestive of homogeneous therapeutic exposure and minimizing confounding effects due to treatment heterogeneity. Treatment outcomes: baseline LVF values were comparable between all the groups, indicating similar cardiac function before the treatment. The median range 55 to 65% suggests that all the patients were started with a preserved systolic function. The final LVF values showed a modest decline in all the patients. All the patients with LVF dysfunction in the concurrent trastuzumab group showed a more than 10% relative reduction in LVF, whereas in the no trastuzumab group, 2 cases showed a more than 10% relative reduction and 4 cases showed less than 10% relative reduction in LVF. Most patients presented with asymptomatic LVF toxicity, and only 1 case of symptomatic congestive heart failure was noted in the left-sided concurrent trastuzumab group. Univariate analysis of factors associated with LVF dysfunction. No single variable achieved statistically significant association with LVF dysfunction, as all the p-values are more than 0.05. However, BMI and comorbidity showed relatively lower p-values, 0.14 and 0.35, possible trends worth exploring in larger samples. Conclusion, concurrent trastuzumab with cobalt-60 RT was generally well tolerated in patients with normal baseline cardiac function. No significant difference in baseline or post-treatment LVF between trastuzumab and non-trastuzumab groups. One patient developed symptomatic congestive heart failure in the left-sided concurrent trastuzumab group, which underscores the need for close cardiac monitoring. Future focus should be based on individualized treatment planning using modern RT techniques like IMRT, IGRT, proton beam, or deep inspiratory breath hold techniques, and long-term cardio protection for breast cancer survivors. Thank you.
Thank you very much for your presentation. Can you please tell me the timing, the sequence of the radiation and trastuzumab? Were they done concurrently or?
Yeah, concurrently. So we started with anthracycline first, and then taxane plus trastuzumab, 4 cycles. And then we started with RT. After completion of RT, we assessed the post-RT 2D LVF function.
Thank you very much. And
Yeah. Yes, sir. So that's the limitation of my study, that the number of patients
I
is
agree,
small.
I agree.
Yes, sir.
Plus, cobalt is, I think, not the standard of care at the moment.
Yes, sir. So most of the government hospitals in our country are still using cobalt-60 for RT planning. So that's why the study represents a real picture.
Thank you, Dr. Arti.
Yes, sir.
Thank you.
Thank you, sir.
So next presenter is Dr. Vikas Kumar Sharma. He will present on the prospective study to compare acute toxicity of concurrent versus sequential hormonal therapy with radiation therapy in post-operative breast cancer patients.
Good morning, all. I am Dr. Vikas Sharma. Today I present a prospective study to compare acute toxicity of concurrent versus sequential hormonal therapy with radiation therapy in post-operative hormone-responsive breast cancer patient. Breast cancer is the most common cancer among worldwide, with 2.3 million new cases reported in 2022. Early detections and timely treatment markedly improved survival, 90 to 95% for stage first, 78 to 86% for stage second, 50 to 74% for stage third, and 24 to 38% for stage four. Management involved surgery, chemotherapy, radiotherapy, hormonal therapy, and targeted agent. Hormone receptor positive breast cancer are treated with selective estrogen receptor modulators like tamoxifen in premenopausal women and aromatase inhibitor, example letrozole, anastrozole, with and without CDK4 and 6 inhibitors, ribocyclic, palbociclib in postmenopausal women. The optimal timing of hormonal therapy with radiotherapy remains uncertain. Whether concurrent or sequential administration of aromatase inhibitor affect toxicity is unclear. Objective to compare acute toxicity, pulmonary and scans of concurrent versus sequential hormonal therapy, letrozoles with radiation therapy in post-operative hormone-positive breast cancer patients. Material methods. It is a prospective study in which 60 histopathologically prone post-operative and hormone-positive carcinoma breast patients were randomized into arms A and B from October 23 to December 24. In the study arm, post-operative patients were treated with concurrent radiation therapy and hormonal therapy, tablet letrozole 2.5 mg daily, orally started 1 week before radiotherapy and continue for 6 months. In control arm, post-operative patients were treated with sequential radiotherapy and hormonal therapy, tablet letrozole 2.5 daily, orally started 1 week post-radiotherapy and continue for 6 months. Inclusion criteria: histopathologically prone post-operative female breast cancers, postmenopausal women, hormone receptor positive women, Eastern ECOG criteria purpose 0 to 2. Patient previously treated with radiation immunocompromised patients, patient with pulmonary comorbidity. Methodology: total 60% with breast cancer who underwent surgery for breast cancer and required adjuvant radiotherapy were selected and randomly assigned in 1:1 ratio into two groups, 30 in each, before receiving either concurrent or sequential letrozole 2.5 milligram daily with radiation therapy. All the patients underwent in IGRT. Statistically analysis: continued variables are summarized in form of mean and analyzed using unpaired test. Nominally categorized variables are summarized in form of the proportions are analyzed and using chi-squares and Fisher's exact test. P-value less than 0.05 is taken as significant. The mean age in the concurrent groups was 55 plus minus 4 years, and the sequential group 56 plus minus 3 years. P-value is equal to 0.08, showing no significant difference. Both groups were age-matched and comparable for toxicity analysis. Lung function parameters showed mild reversible decline in both arms with minimal self-limiting pneumonitis. Skin reactions were predominantly grade 1 and similar across groups. In pulmonary toxicity, pulmonary function test trends over time in the concurrent versus sequential therapy groups. The comparative analysis pulmonary function parameters, force expired volume in first seconds, and force vital capacity ratio demonstrated that both the concurrent and sequential hormonal therapy groups maintained stable respiratory profile throughout the study period, with no statistically or clinically significant decline observed across any of the domains up to 6 months post-radiation therapy. In skin toxicity, radiation dermatitis remained predominantly mild and comparable in both groups, with no significant increase in incidence or severity attributable to the timing of hormonal therapy administrations, thus supporting the dermatological safety of both concurrent and sequential treatments. Summary: no significant difference in acute lung or skin toxicity was observed between concurrent and sequential hormonal therapy with radiotherapy. Both regimens were safe and well tolerated, supportive, individualized, scheduled based on patient preference or institutional practice without compromising safety. Thank you, sir.
Thank you, Dr. Vika.
Good morning, everyone. So we'll be starting our sessions from 9 o'clock. And till that time, we'll start the pre-recorded session. It's a pre-recorded session by the patient, Tamara Husong Millar. Thank you.
Hokkaido, Tohoku, and Western Japan. We currently have about 900 email members. Our mission is to support young survivors so that they can turn their cancer experience into a meaningful journey through information sharing, community activities, and research support. Our vision is to create a society where all young survivors and their supporters can live with hope even after cancer diagnosis. We organize national summits, research collaborations, floor dance activities for recovery, and peer chat meetings. Our funding comes from grants, sponsorship, donations, and merchandise sales. According to our survey, young women worried most about survival and fertility, followed by work, finances, and relationships. These results show that fertility concerns are as significant as survival itself for many young patients. In 2017, Pink Link conducted a national study on the time and financial burden of cancer and reproductive medicine. This research was supported by a Nation Cancer Survivorship Research Grant. In this survey, nearly 500 young cancer patients from across Japan responded, including 343 breast cancer survivors. According to the results, only 70% had undergone fertility preservation using art. The most common reason for not undergoing fertility preservation was that patients did not know about the option or were not offered it. The second most common reason was concern that fertility preservation might delay cancer treatment. And the third was the high cost of the procedures required for preservation. These findings highlight that lack of information, time pressure, and financial burden remain major barriers for young carrier patients in Japan. When asked whether they had a chance to discuss fertility preservation with their healthcare providers, 37% answered no. This means that even though fertility concerns were the second biggest worry of the survival, nearly 40% of young cancer patients in Japan in 2017 had no opportunity to talk about fertility preservation at all. Now, 8 years have passed since the survey I mentioned earlier. Today, the landscape of oncofertility care in Japan has changed dramatically. Since 2021, Japan has implemented public financial support for fertility preservation, and since 2022 for art after preservation. New guidelines and professional laws such as oncofertility navigators and certified oncofertility psychologists are also emerging. What we hope for next? We need enhanced support for fertility and life planning. From the time of diagnosis, patients should receive comprehensive information and access to oncofertility care teams. Financial support and long-term follow-up system must also be strengthened. We also call for continuous survivorship care. Young survivors face ongoing challenges, fear of recurrence, body image, career, marriage, and parenting. Collaboration among medical institutions, communities, and psychosocial experts is essential. Our goal is simple, so that every young woman with breast cancer can choose her own path and live a life that truly reflects who she is. I would like to express my sincere gratitude to Dr. Kumar and all the faculty members for inviting me to these meaningful meetings. Thank you very much for your attention.
That was an amazing, wonderful presentation, and really setting the context for the discussions which are going to happen over the next couple of hours. Very good morning, everyone, and after a good yesterday, I would say packed yesterday, we are off to an on-time start, and we already have gone through one of the sessions of the abstract presentations, and I thank the judges for the first session for navigating that well on time. And I take this opportunity to now invite Dr. Tejaswini to take this session forward. Over to you.
Thank you, sir. We'll be beginning with the fertility management session now, and I extend a very warm welcome to our guests as well as our chairpersons, and I request our chairpersons to please take their place on stage. So first we have Dr. Ananya Diori. Dr. Ananya is an oncoplastic and reconstructive breast surgeon who's done her master's from the prestigious All India Institute of Medical Sciences. She's currently working as an associate consultant in breast and oncosurgery at Medanta, Gurgaon. Dr. Ananya, if you could please come. Next, we have Dr. Hiroko Bando. Dr. Bando is a professor in the Department of Breast and Endocrine Surgery at the Institute of Medicine, University of Tsukuba, Ibaraki, Japan. Next, we have Dr. Puneet Rana Arora. Dr. Puneet is a fellow in the Royal College of Obstetrics and Gynecology. Dr. Puneet is a gynecologist and an infertility specialist. Over to you, Dr. Diori.
Good morning, everyone. So, the first session today is fertility preservation in breast cancer patients by Dr. Sabhyata Gupta. Ma'am is the chairperson of gynecology and gynec-oncology at Medanta Medicity, Gurgaon. I welcome ma'am to kindly take the dais.
Good morning, everyone. As said, I'll be speaking on fertility preservation in young breast cancer patients. And the presentation prior to my presentation has fully justified this session now. So because of the development of anti-cancer treatment, which has led to improved treatment outcomes, there is increased survival rate, there is better quality of life. And when that happens, automatically the young patients, they desire to have their own biological children. So there comes the need of fertility preservation in these patients. And because of the advanced assisted reproductive techniques, we can offer and we can help them realize their dreams. So the major concern is because these patients are subjected to gonadotoxic chemotherapy, and then in certain patients there is age-related decline also because they are offered endocrine therapy for a long term. So during my presentation, I'll take you through the treatment-related infertility risks, options for fertility preservations, the safety factor, and the barriers to oncofertility counseling. Regarding the impact of systemic therapy on fertility, it's the type of drug which is being used, the dose, the frequency, and the most important drugs are cyclophosphamide, and we know that the alkylating agents are very badly gonadotoxic. Anthracyclines again are gonadotoxic, so are taxanes, but they are not as bad as cyclophosphamides. And the treatment-related amenorrhea happens in around 83% of patients. And when the amenorrhea happens, almost in 1 year's time, 70% of the patients, they resume their menstruation. And in 2 years' time, around 90% of the patients, they resume their menstruation. But the resumption of menstruation does not mean fertility preservation. You know, they may not conceive. Their ovarian reserve goes down, their fertility may decline. And this is because of the treatment factor, which I just enumerated, and the patient factor, that is the age of the patient. It's seen that the ladies who are more than 35 years of age, they have 3 times more chances of getting this amenorrhea, the treatment-related amenorrhea, as compared to the ladies who are less than 30 years of age. The other patient factor is the ovarian reserve prior to the initiation of treatment. And the third is her BRCA status. Amongst the BRCA carriers, you know, that there's data which is for and against. Data says that there's decreased ovarian reserve, elevated susceptibility to chemotherapy. They experience menopause 1 to 3 years earlier, and the cryopreserved ovarian tissue show a lower number of oocytes per fragment. But then there are studies which say that there is hardly any difference between the people who are not BRCA positive and those who are BRCA positive regarding the amenorrhea induced and the low level of AMH. So we need to have more studies to know exactly what is the risk of treatment-related amenorrhea and premature ovarian insufficiency. Just briefly about the drugs, as I said, alkylating agents are highly gonadotoxic. The gonadotoxicity is almost to the tune of double as compared to the other ones. And the possible damage happens to the non-growing primordial follicle pool. That means that's a basic ovarian reserve which gets affected in these patients. Doxorubicin and taxanes which are used are also gonadotoxin, but they are less. So whether you give it in a sequential manner or you give it in a combination manner, the risk remains the same, almost similar. Whether you give a dosed and schedule or you give a standard regime, the amenorrhea risk is again similar in both the groups. There is significant increased risk of amenorrhea when we offer hormone suppression to patients who are hormone receptor positive in the form of tamoxifen, which we give for a longer duration. But the good point is that the reversibility is very good. The reversal happens in more than 95% of patients. Coming on to the HER agents, the anti-HER agents, there is significantly lower 18 months amenorrhea in these patients. In fact, it has been seen that when trastuzumab was added to the chemotherapy, the AMA reversal was much better and higher as compared to the ones who were not given HER2 agent along with chemotherapy. The cyclin-dependent kinase, the target therapy which is being researched in young breast cancer patients, there is hardly any data available on gonadotoxicity, and same holds true for PARP inhibitors in humans. Though in the animal model it is seen that the gonadotoxicity is to the tune of 36%. Immunotherapy again is being used for young breast cancers also, and there is not much direct effect which is known on premature ovarian insufficiency, but yes, immunotherapy causes thyroiditis, adrenalitis, and the hypophysitis, and this causes the change in the axis, that's the hypothalamic pituitary ovarian axis. Hormonal regulation is hampered, and so the fertilization gets affected. So in these cases, we need to give appropriate HRT to maintain fertility. So we need to engage with the endocrinologist and the reproductive specialists as well. So when we are, offering the fertility preservation strategies to the patient, the factors which are to be considered are the age of the patient, the severity of the disease, cancer stage, urgency of immediate treatment, whether it's there or not, marital status of the patient, future pregnancy desire, and what is the maximum time available interval between the initiation of the cancer therapy and the time available for ovarian stimulation. And the various methods which are available to us are oocyte cryopreservation, embryo cryopreservation, ovarian tissue cryopreservation, and GnRH analogs. Briefly about the various procedures. Embryo cryopreservation is offered to ladies who have a male partner. It's a stable method and has high chances of fertility. Oocyte cryopreservation is meant for those without male partners, but both methods are well established and widely clinically implemented. And even the results are almost comparable. You know, with the advancement in the ART, they are almost comparable in embryo and oocyte cryopreservation now. It takes around 10 to 12 days to complete ovarian stimulation and oocyte retrieval. And so you don't, lose much time in getting the fertility preservation technique in place. And it should be offered before initiation of systemic anti-cancer therapy. And if at all that is not possible for some reason, then at least 6 months washout time is given after highly gonadotoxic treatment like cyclophosphamide, and maybe 3 months time for the less gonadotoxic treatment. So these procedures, they do not delay the time interval between the surgery and the chemotherapy, and the random start ovarian stimulation protocol does not allow any delay in the initiation of neoadjuvant chemotherapy. Briefly about what happens in these ovarian stimulations and oocyte retrieval. So, controlled ovarian stimulation and oocyte retrieval are very safe and convenient outpatient procedures. They can very well be done in the OPD, or not OPD, sorry, the daycare areas, and the complication risk is very less. It can, if at all it happens, it can be some hemorrhage from the puncture site, or it can be ascites because of the ovarian hyperstimulation syndrome. And if at all you are anticipating that, she will get she is a high risk for ovarian hyperstimulation syndrome, then cabergoline and GnRH antagonists are given for prevention. And if at all it happens, again, you don't have to worry much, because, the progression will not happen in these patients, because in these patients we are not going to implant the embryos back immediately. And the spontaneous regression of OHSS happens. So the random start ovarian stimulation protocol is the one which is offered to these patients and is the favored one. And normally we know that the ovarian stimulation is started in the early phase of, early follicular phase, early phase of menstruation after menses. And so, we'll end up losing some time if at all we are offering this to the patient who's about to get the breast treatment done, breast cancer treatment done. But in the random start ovarian stimulation treatment, we can stimulate the ovary in any phase of menstruation. So we don't have to wait for the follicular phase only. So that way we save time. And coming on to the fact that, with ovarian stimulation, we think that the E2 levels are going to go high, and that may hamper or may negatively impact the cancer progression and future prognosis also. So this is the addition of aromatase inhibitor, that's a letrozole. With this combination, it eliminates such a concern, and it inhibits the rise of serum E2 levels. Then there is a term called dual triggering, which is meant for, this is done after ovarian stimulation and before egg retrieval. You trigger to allow better maturation of the ovum. So here again, the dual triggering can be given to these patients so as to have more number of oocytes and also good mature oocytes. Similarly, double stimulation is done for these patients, and that is again to have more number of oocytes. So to give them the best possible number of oocytes and the healthy oocytes, this all is in place in ART now, and this should be discussed. I mean, the doctors should know it, and it should be discussed with the patient also. The other thing is the ovarian tissue cryopreservation, wherein you do not have to stimulate the ovary. It is the ovarian cortex which is preserved, and this will preserve the fertility, this preserves the hormonal production also, and there is no delay in chemotherapy, and it's a clinically established method. It's no more an experimental thing now. And to enhance the viability of transplanted ovarian tissues and maximize pregnancy rates, it's important that you avoid cryo injury during freeze-thaw process and minimize ischemic injury during transplantation. So this is not contraindicated in breast cancer patients also, except for the metastatic cancers. and the patients who have very high risk of relapse. This is one review of literature wherein they saw that 16 patients underwent stimulation and transplantation, the cryopreservation and transplantation, and what we see is that this transplanted ovary, it starts functioning in 1 to 5 months of time, and it maintains function for 15 months. And the pregnancy achieved in this survey was at least once, 12 patients conceived, and total number of the pregnancies were 14 and 11 live births, pretty promising that way. So this, again, there is some concern that when we are preserving the ovarian tissue, whether we'll be, transmitting some cells which are still there in the malignant cells in the ovary. So this 7 studies review has shown that there were no tumor cells seen in this, these fragments. But then, having negative result from one small fragment cannot ensure that the whole entire, whatever we have preserved, ovarian tissue is not having the cancer cells. And then in this review only, they could see that there was recurrence in 2 patients. And, but what all said and done, the limitations are there, but it is undisputedly a very promising method. Then the other thing is in vitro maturation, wherein you take the immature ovum from the ovary. So you don't have to waste any time for that matter. If you have no time in between, you can offer this to the patient. Ovarian suppression, I think everyone sitting here knows that ovarian suppression is something which can be offered to ladies here, and it inhibits the circulating levels of gonadotrophins. And it should be given, it's given before and during chemotherapy to protect ovarian function. Everyone is aware of the POEMS and PROMISE trials, which have shown that it prevents ovarian insufficiency and yields a higher pregnancy rate. But ESHRE and ASRM, that's the American Society of Reproductive Medicine, they say that this is a corollary option along with other fertility preserving methods. An alternative, if other methods, they are contraindicated. And ESCO guidelines also say that the GnRH therapy is recommended when other established fertility preservation methods cannot be implemented in young breast cancer patients. We've been offering pregnancy to these ladies, we've been offering fertility preservation, but there is a theoretical risk always in the minds of many people that the high estrogen status during pregnancy may cause cancer relapse. So there is ample data studies available which says that in fact the ladies who got pregnant significantly had better disease-free survival and overall survival as compared to the patients who did not. And mortality rate was 46% lower in this setup. But whatever we are planning to do, we have to ensure that the anti-estrogen treatment is given for 2 years, and after 2 years you look for that there is no disease there, and then you stop tamoxifen, which is a teratogenic drug, for at least 3 months, and then allow the pregnancy to happen. And this is a positive trial which is still going on, which will tell us about the impact of temporary endocrine therapy interruption to allow pregnancy and to confirm the safety of pregnancy in breast cancer survivors. Coming on to the barriers, we've been talking about offering fertility preservation, but then there are barriers. Barriers at the level of physicians, wherein at times the information is not there. At times they can't, collaborate with the other teams. That becomes a constraint. At times the BRCA status is not known to them, and as we know, the 5 to 10% are breast cancers are related to hereditary problems, and out of that 80% are germline mutation, BRCA1 or BRCA2. So, to prevent that hereditary cascade later, I think it's important to know BRCA status, and these patients at times the egg donation and surrogacy is also recommended. From the patient side, patient is so disturbed with the diagnosis itself. It's seen that around 27% of the patients don't even talk about the fertility preservation with the doctor, even if the doctor wants to talk about it. And so then of course they think that the relapse may happen. They just do not know how long the longevity of the life is going to be. and how long they can actually offer a good parenthood to the child also. And then comes the, the financial constraint. So everything put together, at times, they do not opt for it. Of course, they need to have good supporting system also if they want to go for it. And so communicating and discussing with patients in decision making is very important. So patient, of course, everyone needs to know it. Everyone, the doctor, the patient should talk about it. There are several, decision aids are available which have been developed and systemized, and they've been proven to be effective. And so they should be distributed in the OPD areas to the patients. But important is crucial one-to-one counseling, and multidisciplinary team approach is important, wherein we have to involve the medical oncologist, the surgeon, the fertility specialist, and the psychologist. So I conclude by saying that pregnancy does not negatively impact the prognosis of breast cancer. Fertility preservation before cancer treatment should be strongly encouraged. Prioritize eliminating barriers. Share decision making with multidisciplinary team for appropriate future life decisions is important. Provide adequate information at the right time. That's very crucial. And early referral to a fertility preserving specialist should be done, because that's the key to success. Thank you very much.
Thank you, ma'am. Our next speaker is Dr. Prakash Chitalkar, who will be talking about managing reproductive and psychosocial issues in young women with breast cancer. He is the Vice President and Convener at the Teenage and Young Adult Cancer Foundation, and also the Director of Cancer Center, Professor and Head of Department of Medical Oncology at SAIMS, Indore. Welcome, sir.
First of all, I must thank Dr. Ashok Vaid and Dr. Rakesh for inviting me for this wonderful 2-day session on young women's breast cancer. And I think it's been eye-opening yesterday, especially the sessions. And well, I bring you greetings from the Teenage and Young Adult Cancer Foundation, which is not only focused on young people's breast cancer, but also several other cancers, all occurring in the age group of 15 to 39, the most happening era of the human life. And India being a young country, we got a huge population in this age group. And now the ICMR has brought out data saying every 7th patient of cancer in our country is a young patient by definitions. So Dr. Sabita has made my job very easy. She has elegantly discussed the entire gamut of the reproductive care of a young woman with breast cancer and the fertility preservation. So I'll essentially take the liberty of focusing on psychosocial issues and in young people with breast cancer. The Teenage and Young Adult Cancer Foundation is a national association of oncologists, but also a non-profit, where our dream is that every young person with cancer must get a chance for cure and live life's dream to the fullest. And our target groups are 2: young persons with cancer and survivors of childhood cancer. Survivors of cancer, childhood cancer means they then come in the adolescent and young adult age group, and their issues and their problems remain the same. So we address them, and our aim is to reach every young person with cancer by 2030. The ICMR now is, in 2022 is now approximately nearly 2 lakh new young patients from cancer now being diagnosed every single year. And in India, almost 34,000 deaths in cancer occurring because of breast cancer below the age of 45. They can receive optimal treatment, doses, intensity with fewer comorbidities. The unique thing about young people is oncologists are all the time engaged with problems of handling comorbidities while treating cancer in the advanced adult age group. But young people don't have comorbidities. They may have some developmental abnormalities to trade off for the comorbidities, but otherwise they remain very robust, and they're capable of taking the most intensive therapies, just like the pediatrics. Reproductive ability, fertility, psychology, and autonomy are among the unmet needs, and we'll discuss that a little as we go back. Young person is usually accustomed to a childhood and adolescence of struggle and adversity. But in India, we have a huge population of young aspirational persons. They live in the future all the time. They're digitally savvy, and they have a clear perception of the reality and clear questions to the doctor. Very often, the parents or the elders in the family come into your chamber, and they keep the youngster outside waiting for the discussion to happen. So it's very important to encourage the young person also to join the discussion, and you will find that in this era, he'll ask you the most pointed questions and come out with the most pointed responses. Like he'll say, oh, my leg will be amputated, but I'll be okay, and I'll not die, right? That you don't expect a 50, 60-year-old man to ask you that question by himself directly, but a young boy or young girl could ask that. So it's a very dynamic system of the many disruptions in life happen in the adolescent, young adult age group: body image, emotions, trust in health, career, education, finance, family dynamics, future plans, fertility, peer relations, healthy behavior, and self-esteem. There are so many. But the clinician's role remains pivotal, because the primary care oncologist will remain pivotal to the understanding of the young person with cancer as a person. He not only needs to understand the molecular landscape, he must also understand the mind space of the young person. The psycho-oncology and counseling should be integral to the oncology training in the postgraduate programs, the DNB and DMs. And I think what most heartening is since 2015, there's a burgeoning of psycho-oncologists in our country. I very clearly remember the Taikan Foundation organized a symposium called Voices of Young People with Cancer in 2015, along with the ISMPO, and there were hardly any psycho-oncologists in the audience, and mostly the clinicians were discussing all the the mental, psychological problems. But today, the hall, if you say psycho-oncology, you'll find so many young psycho-oncologists dissecting the patient's mental status very, very elegantly and beautifully. And they are very dynamic, and they are a great resource now to the medical oncology community. The psycho-oncology support is necessary, and a PsyOnc must be part of the MDT, multidisciplinary team. Choices we make and shared decision making. Finding a lump in the breast, a very young woman who's just got a job in a large metro, who lives alone, that can be very frightening and very isolating. She consults a doctor accompanied by maybe a partner or a spouse or in-laws or parents or whatever. Prospects of marriage, events, trying to become pregnant, all those things may be there already working on her mind when the cancer diagnosis is made. Issues of privacy, agency, and autonomy are very important. And each one of them is important because her privacy has got to be respected. We need to discuss things very often with her individually, and then maybe along with her partner when she says that it should be so. Then she must be given the agency and the autonomy to take the decisions as far as the choices of fertility preservation which are given, as discussed by my previous speaker. Delays in presentation and delays in diagnosis become inevitable, or if you can avoid them, we medical oncologists treat very high-grade tumors. We treat lymphomas, leukemias, among other things also, young people with breast cancer, and sometimes those delays can be very anxiety-producing, both for the clinician and for the patient. The delays in therapy, waiting for fertility preservation can be very difficult therefore. And choice of local therapy has to be, yesterday we had a very good discussion on oncoplastic surgery and the choices of local therapy, its impact on body image, impact on her personhood, and all those things are extremely important when we counsel and when we actually deal with the patient. The common scenarios are families invariably present. They may or may not allow the patient to give a very clear perspective of her own. The patients and the spouse must be encouraged to participate. Fertility seems an extraneous concern compared to the risk of cancer. The urgency of cancer diagnosis, risk to life, and urgency of therapy. And these are all important things. Whether the patient and the family is worried whether cancer might kill the patient if you keep on, we spend time doing fertility preservation. So we need to allay those anxieties, and reasonable time, as Dr. Sabhyata has described in detail how much time it takes to ovarian retrieval, etc. All those need to be emphasized, and I think it's possible to even give a pre-phase or a single agent treatment in the beginning and so on. The multidisciplinary team emphasizes the need for oncofertility procedure prior to initiating. I'll quickly go to a illustrative case. In year 2000, in the armed forces, I had an army dentist and a paratrooper woman. She was 34 that time, and the mother of one daughter. The day the diagnosis was made, her marriage actually broke apart. But she did not give up. She finished treatment. She even had those days the only thing was a surgical oophorectomy for estrogen receptor positive breast cancer. She celebrated the second anniversary of cancer with a 200,000 kilometer drive across India between May and October 2005. All four corners of India, Arunachal, Dwarka, Siachen Glacier and down to Kanyakumari. In a single, she drove all by herself with her daughter. Organized 300 women cancer camps on the roadside during this trip. Remains a leading cancer motivator and patient advocate today at 59. Celebrated the 10th cancer anniversary atop the Siachen Glacier once again. And can you imagine, she's running an NGO called Highways Infinite, and she's active as of today. So that's the best case example, completely full of spirit and dynamism and positive. And the second one is a 25-year-old woman who got selected for the State Public Service Commission. Great. Again year 2000, developed aggressive triple negative breast cancer, received chemoimmunotherapy later, not immunotherapy, progressed rapidly. However, she accepted her condition, moved to a palliative care center, took care of other patients in the palliative care center and lived for 9 months in palliative care center until she died. So there are two extremes. One was complete acceptance and other one was complete defiance. And both these things happen in young people. It's possible. They are very mature, and we need to actually, so these are the things, we need to create a system so that young people understand disease, understand life, understand cancer, and then learn to network to take care of each other. So I was very heartened by the Dr. Rakesh presentation yesterday, where he actually is going to educational institutions, staying with the educational institutions for 8 to 10 years in order to sensitize them and create a dynamism in the young people so that they start looking at those catastrophic diseases, catastrophic events in other people differently. How one feels inside, balancing emotions and having control over them, self-esteem and confidence. All these things are important and they come in the developmental process. I'll discuss that in the next 4 slides. So resilience and bouncing back is essential. This is very characteristic of a young person with cancer. The disease changes, the loss of work, loneliness, feeling burdened by the emotional responses of friends and family, concerns about managing their distress as well as those of parents and friends. Those become the important things. Interpersonal problems continue to be important. Prone to peer conflicts, as peer advice is considered doctrinal by AYS. A young person believes his peers more than he believes his parents, he believes in anybody else. Relationships may seriously affect mental and emotional well-being in the context of the new reality of the cancer diagnosis. The body image, of course, remains very critical to a young woman with breast cancer, loss of hair, and mastectomy, etc. And of course, so many sad problems, they always remain at the back of the minds of such patients. So depressive symptoms, suicidal tendencies, phobias, they are all very, very common, and this will be a huge gigantic task in order to create MDTs, have a psycho-oncology support and to start delving into them, and over a period of 5 years or 7 years you'll finally start seeing differences as we see. So prevalence and risk of psychosocial distress is actually considerable. Almost a third or a fourth of every patient, all the patient cohorts have psychosocial distress and depression. Now I'll discuss some cartoons about what happens to a brain of adolescents. There is firstly a process of pruning of neurons, and secondly a process of increasing myelin formation. So there's a pruning because a child is, babbles and does everything, and but then as he grows into adolescence, he becomes more selective, but however the neurons run faster, 3,000 times more faster. And the ultimate aim is to integrate the brain. And however, by the time, this is very common to have young persons with breast cancer, 21-year-old, married for only 2 years in the village, etc. So finding your sense of tumor, a young woman with breast cancer walks into your clinic not long after this brain. So she's recently had these neurological developmental things in her head, and then she gets an unfortunate disease like cancer. So what is the aim then? There is so many things happening. The nature, as we discussed, and nurture community mores, family structure, partners' expectations, past medical illnesses, comorbidities, nutrition and self-care. All these things create a panorama of cause and effect. And a clinical psychologist, a clinical oncologist, a cancer provider like us, we have to be aware of all these things. The interplay of nature and nurture determines the unique coping equation or coping situation of every individual. Every cancer patient has a own coping system. Young person's neurobiological takeoff point is integration, and what he expects is kindness and compassion. And therefore, compassion, insights, shared decision making are critical in counseling a young woman with breast cancer. The role of parents and teachers are there. Therefore, it's very exciting that we have the Breast Cancer in Women Foundation in the state of Uttarakhand doing this actively in the community. Quickly, while talking about reproductive health of a young person with cancer, the only thing left is now pregnancy-associated breast cancer. I think my subsequent speaker is going to talk about it. About 8% of them in the Indian study actually showed pregnancy-associated breast cancer. And implant-based and other reconstruction also done. Advanced stages, delay in diagnosis. These are common problems with pregnancy-associated breast cancer, which is simply defined as either during pregnancy or in the 12 months period after pregnancy. Anthracyclines and taxanes safely given in the second and third trimester. Anxiety about survival of child and about safety of breastfeeding. These are the Tata Memorial findings published in 2021. And of course, the positive trial interrupting endocrine therapy and attempt in pregnancy after breast cancer. Just like in chronic myeloid leukemia, we medical oncologists started doing treatment-free remissions. Similarly, a breast cancer patient who is HR positive, maybe we can stop the hormonal therapy, allow her to get pregnant, have a baby, and then restart the treatment. So these things are now possible in 2025. Healthcare after completion of therapy, just to say briefly, fatigue, chemo brain, ovarian failure after surgical oophorectomy will require an HRT over a period of time. Managing skeletal integrity over several years. Late effects of chemotherapy like cardiotoxicity needs to be managed. Interstitial lung disease, just like drugs, trastuzumab deruxtecan, ovarian failure, osteoporosis, second malignancy, and syndrome X. These are realities of a survivor's life, and as medical oncologists, we need to keep a survivor clinic ready for managing the various things. So this is our editorial long time back. Survival increments in AYA cancer could reach up to 5 decades with impassioned social entrepreneurship. It could be the ultimate frontier of cancer care. And I think we are getting there. A young person's breast cancer should be approached through a prism of neurobiological development, desires and life goals. This is a dynamic, intuitive field of care and is one of the ultimate frontiers of oncological excellence. It takes a multidisciplinary team to unravel the unique persona of a young person with breast cancer and deliver holistic care. Thank you very much.
Thank you very much, Dr. Shitaoka. So let's move on to the next speaker. Let me introduce Dr. Kitano Atsuko. She is from Japan, and she's a good friend of mine. And she's a medical oncologist who works at St. Luke's International Hospital in Japan, and she's one of the key contributors for developing national guidelines for young adult IS generation breast cancer care. Thank you very much. Please start, Dr. Kitano.
Good morning, everyone. It is my great honor to present at this conference. I will talk about the issue related to pregnancy after breast cancer treatment with introducing the Japanese context and the recent evidence. In recent years, fertility preservation has become an integral part of cancer care for young patients. Referral to reproductive medicine specialists before starting cancer treatment, providing an appropriate explanation of fertility preservation option, and supporting patient decision-making through a multidisciplinary team have become the new standard of care for young cancer patients. In Japan, there were 2 clinical guidelines related to fertility preservation. One is published by Japanese Society of Clinical Oncology, JASCO. The other one is published by Japan Society for Fertility Preservation, JSFP. JASCO's guideline covers 11 different cancer types, while JSFP's guideline focused especially on breast cancer. With the statement of clinical guideline, public subsidy program for fertility preservation was introduced in 2021. At the same time, National Registry Program on Fertility Preservation was also launched. Since 2022, the public subsidy system has also been expanded to cover the cost of returning cryopreserved embryos or oocytes, sperm, or ovarian tissue through assisted reproductive technologies after fertility preservation. The addition of fertility preservation option has brought new hope to young breast cancer patients. The next challenge, however, is when should we try pregnancy? Some patients choose try to pregnancy after completing standard cancer treatment, while others interrupt their therapy to pursue pregnancy. Sadly, there are also patients who are forced to give up the hope of having children. There are various challenges and issues related to pregnancy after breast cancer treatment. Number one, increased risk of perinatal complications. Number two is pregnancy following interruption of endocrine therapy. Number three is breast cancer recurrence during pregnancy. I will explain each of these issues in detail. Number one is increased risk of perinatal complications. A large meta-analysis by Lambertini et al. Analyzed outcome of pregnancy after breast cancer. It demonstrated a significantly increased risk of perinatal complications, particularly low birth weight and preterm birth. However, importantly, disease-free survival and overall survival were not worsened by pregnancy. In fact, patients who become pregnant after treatment showed prolonged DFS and OS compared with those who did not. This findings provides the assurance that pregnancy after breast cancer can be safe from an oncological standpoint when carefully timed. Second issue is pregnancy following interruption of endocrine therapy. For hormone receptor positive breast cancer, tamoxifen for 5 to 10 years remains the standard of care. The ATLAS trial published in The Lancet showed that extended tamoxifen to 10 years reduced recurrence by 3.7% and mortality by 2.8% compared with 5 years. However, for young women, this additional 5-year tamoxifen often means losing their window of pregnancy. Some patients wish to interrupt endocrine therapy temporarily to pursue pregnancy. The positive trial published in the New England Journal of Medicine 2023 was designed to answer this very question. It included the patient aged under 42 years with stage 1 to 3 hormone receptor positive breast cancer who had received at least 80 to 30 months of endocrine therapy. After the 3-month washout period, they were allowed to attempt pregnancy for up to 2 years. Here are the results regarding breast cancer-related events that were first reported in the New England Journal of Medicine in 2023. After the median follow-up of 3.4 years, 44 breast cancer-related events were observed, but the rate was same to historical control. This slide shows the 71 months follow-up result of the positive trial compared with the soft text studies that was presented in the ESMO in this year. For the breast cancer-free interval, the 5-year event rate was 20.3% in the positive group and 30.2% in the soft text group, with a hazard ratio of 0.88 showing no significant difference. On the right figure for distant recurrence rate, on the right figure for distant recurrence-free survival, the 5-year rate was 6.2% versus 8.3%, with the hazard ratio of 0.767. In summary, temporary interruption of endocrine therapy to attempt pregnancy did not increase the risk of recurrence compared with continuing endocrine therapy. As shown here, this slide presents the subgroup analysis of 5-year breast cancer-free interval. Interestingly, we can see that HER2-positive patient had a lower incidence of events compared with HER2-negative patients. On the other hand, with 4 or more positive lymph nodes or those with large tumor sites experienced breast cancer-related events in more than 20%. This finding suggests that the tumor burden still plays an important role in recurrent risks. This slide summarizes the pregnancy outcome in the positive trial at a median follow-up 71 months. Among 497 evaluated patients, 377 women became pregnant at least once. Most pregnancies were full-term, and only 5% were preterm. The most common pregnancy complication was hypertension. About 8.6% of babies had low birth weight, and 1.8% had birth defects, which rates are similar to those in the general population. Research group will continue further follow-up until 2029. In positive trial, 84 patients were enrolled from Asia Pacific Middle East region, including 62 participants from Japan. The trial in Japan was conducted with the support of Japan Breast Cancer Research Group. Dr. Chikako Shimizu, who is also the faculty member of this conference, served as the principal investigator for Japan. The study was also supported by research grant from Estée Lauder Japan. Third issue is breast cancer recurrence during pregnancy. With the spread of fertility preservation and the growing evidence for temporary interruption of endocrine therapy, more breast cancer survivors are seeking pregnancy. We are also seeing more patients who wish to return frozen embryos preserved before cancer treatment. Although rare, we do sometimes encounter breast cancer recurrence during pregnancy. This slide shows a case from our institution, a woman in her 40s who had undergone surgery for left breast cancer, but she discontinued tamoxifen after 2 years to pursue pregnancy. She became pregnant using frozen embryos preserved before cancer treatment. At 13 weeks of gestation, she felt leg pain and was diagnosed with multiple bone metastases. She received paclitaxel therapy during pregnancy and continued metastatic cancer treatment after delivery. However, she passed away about 5 years later after delivery. She said, becoming this children's mother was the greatest happiness of my life. Although rare, such cases such cases may become more frequent in the future. Therefore, we need to build a medical care system capable of managing breast cancer during pregnancy. While NCCN and ESMO have already published guidelines, Japan has now begun developing its own national guideline for cancer during pregnancy. We also believe that establishing a patient registry system for pregnancy-associated cancer will be improve care and research in this field. I have introduced 3 issues related to pregnancy after breast cancer treatment. Concerns about pregnancy and childbirth among breast cancer survivors often change through their patient journey. Fertility preservation is never the final goal. It is only one step along the way. Therefore, we must provide continuous engagement and support as part of survivorship care. This photo shows members of Pink Ring, a Japanese support community for young breast cancer survivors. Many young women with breast cancer say that at the moment of diagnosis, they feel that their future suddenly disappears. To fulfill the hopes of young breast cancer patients, it is essential to strengthen our connection across Asia and work together to create evidence. Once again, I would like to express my sincere gratitude for the opportunity to speak at this conference. The third International Conference on Young Women's Breast Cancer and Health will be held next year in Tokyo, Japan, on November 14th and 15th. November is autumn season in Japan, when the autumn leaves are especially beautiful. The venue will be located near Ginza, one of the most vibrant and elegant area of Tokyo. I hope you will enjoy not only the scientific session, but also the wonderful culture and sights of Japan. We truly look forward to welcoming Tokyo next year. Finally, thank you for, again, organization, the colleague in India, especially for Dr. Kamal. Thank you for your attention.
Thank you so much, Dr. Atsuko, for a nice talk. Thank you to all the 3 speakers. I think we can have some questions if there are any from the audience. Any questions you have? I would just like to comment on 2 things, I think, which have been highlighted very well in these last 3 lectures is Dr. Chitalkar's mentioning about the involvement of psycho-oncologists, and I would add on to it that patient navigators. They really help to what I have seen in our clinic, Oncofertility Clinic, is increasing the uptake and making them more involved in the oncofertility care. And Dr. Atsuko's mention about it's not only the fertility preservation, I think it's a survivorship is important, and I think we also reiterate that we just don't offer preservation, we follow them after so that at least they utilize their gametes, what they have frozen, and if not, at least they help us to decide what to do with it in case they don't want to use it. So thank you so much for highlighting these things. And thank you to organizers for having us on this dais. Thank you.
Thank you so much. I would like to call the chairpersons for next session. Session is on loco-regional therapies in breast cancer in young women. And I would like to call Dr. Prakash Chitalkar from Indore and Dr. Richa Chauhan from Patna.
Thank you. I'll invite Dr. Hiroko Bando, Professor Breast and Endocrine Surgery, Institute of Medicine, University of Tsukuba in Japan. The topic is regional therapies in young women with breast cancer, balancing aggressive biology and quality of life. Dr. Bando, please.
Thank you very much again. My name is Hiroko Bando from Japan. Thank you very much for inviting me to this very important conference, and I'm very excited to share my talk with you. So today I am going to talk about what kind of operation method would you offer to your young patients. So in Japan, we have a lot of young people, but not as much as India. Young breast cancer accounts for about 6 to 10% of all cases all over the world, I guess. And proportion of young breast cancer has remained relatively stable over the time in Japan, but the number of the whole breast cancer patients are increasing, so we see a lot more young patients as well. The distribution of breast cancer subtype by age groups are different. Yesterday we have learned a lot. The younger age has a lot of more aggressive tumor subtypes, like triple negative breast cancer and HER2 positive type, and which is very same for the Asian population as well. In Asian population, poor prognosis for younger patients with hormone receptor positive, HER2 negative, or triple negative breast cancer compared to mid-aged group. Mid-aged group, I mean with a 40 to 49. So if we look at the survival data, age 40 to 49 is the best. And then comes with the age younger than 40, and then age more than 50 comes the worst, which is very true for the hormone receptor positive and the triple negative breast cancer patients. As introduction, I would like to summarize the young breast cancer patients account for 6 to 8 or 6 to 10% of all cases. More aggressive subtypes are very popular, and even the tumor stage is the same, worse prognosis compared to the older woman, older or 40 to 49 mid-aged group. And the emotional psychosocial burden is very significant. So how about this operation? Should we do the mastectomy or should we do the breast conserving surgery? And from the very history, we know that this prognosis of mastectomy and breast conserving surgery plus radiation is almost equal in terms of any age or disease-free survival, distant disease-free survival, or overall survival. The meta-analysis comparing breast conserving surgery versus mastectomy in younger patients, if we look at it, then of course the stage is different, but generally summary hazard ratio indicates a borderline significant reduction in survival risk of 10% for breast conserving surgery group. So which means the breast conserving surgery is quite feasible even for the young patients. How about in Asia? We have data about the Malaysia or Singapore or Hong Kong cohort aged less than 50, so it's not the real young, but at least almost premenopausal, and it's very big data. And if you look at those data, we see the 5 years overall survival. There is no difference in terms of mastectomy or breast conserving surgery. So the type of the surgery was not significantly associated with survival outcomes. How about in Japan again? We have seen that the patients who are the youngest, I mean less than 35 years old. I see this picture from yesterday, but in multivariate analysis, surgery procedure was not associated with poorer prognosis. So maybe breast conserving surgery may have slightly higher local recurrence, but equivalent disease-free survival or overall survival with adjuvant radiation treatment. So young age is not an indication for mastectomy. How about the choice of the surgery? How is it chosen? In Japan, we have the large data from 2004 and 2006, so it's a little bit old data, but younger age, I say again, it's less than 35, do have a little bit larger tumor, like T2 is most common, and T3, 20%. But the breast conserving surgery was more common in those young population. When the patient is a little bit older, of course they have the screening program, they find the tumor smaller, but they tend to have more mastectomy than breast conserving operation. How about in the other Asian cohort? Again, in the Malaysia, Singapore, Hong Kong, it depends on the country and it depends on the culture. But at the what we can see here is mastectomy is rather more common in breast conserving surgery in the younger generation. How about in the United States? In the United States, it's been told that breast conserving surgery is more common. It's common 60 to 70% all over the time. But in younger generation, the mastectomy is more common. Like patients who are at the 20s or 30s, about 60 or 80% of the patients are done mastectomy, even if the tumor is very, very small. How about in Korea and US, what are the reconstruction rate after the mastectomy? It depends on the time again. In Korea, in 2015, the breast reconstruction rate after mastectomy was almost 20%, but it raised up to more than 50% in 2018, so it's increasing. In the United States, the increase was a little bit more earlier. It started a little bit more earlier. The breast reconstruction rate is almost 60% in the United States. So in South Korea and the United States, reconstruction surgery for mastectomy cases is very, very popular. However, in Japan, we see that the patients who have the reconstruction is much more less compared to United States or Korea. So in this area, in 2020, breast conserving surgery was chosen for 43% of the patients, but more than half of the patients had a mastectomy. And for patients who had mastectomy, only 17.5% had reconstruction. The reconstruction was done by implant or autologous graft. It was almost half. So breast conserving surgery, mastectomy, or reconstruction rate is very different from time to time and place to place. In Western or UK and US and Korean data says body integrity emphasized. Reconstruction is usually seen as part of recovery, so it's very common, and I think there is a strong social support as well. On the contrary, Japanese context, survival comes the first. So reconstruction often viewed as a secondary importance. And if I talk to my patients, would you like to have a reconstruction? Many patients say, is it necessary for me? So it doesn't matter, do I like to have it or not? Is it necessary? So that's what it means. So maybe cultural modesty depends on the choice of the mastectomy. And of course, there is an access gap or information barriers as well. So the choice of surgery and surgery procedure selections for young breast cancer patients varies considerably by country. Breast reconstruction decisions are shaped not only by medical practice, but also by cultural identity and personal values. So supporting informed, autonomous choice is very essential. Now, how about the surgery for individual risk with genetic risk? In the NCCN guidelines, no one says that the patients with BRCA mutation should have the breast mastectomy, but it recommends to discuss options of risk reduction mastectomy, but the age and life expectancy is very important. On contrary, Lee-Fraumeni syndrome is different, so we should not do the radiation, so we should do the mastectomy for this type of the syndrome. But this difference is here. Breast conserving surgery and mastectomy in BRCA mutation carriers, do they have their prognosis is different? There is a very large cohort study from China. Of course, it's not a randomized study, it's a retrospective cohort study. But if you look at closely, for the BRCA1 mutation carriers and BRCA2 mutation carriers, distant metastasis-free survival and overall survival are almost equal. And also, the data from Korea also supports this background as well. The patients with BRCA mutation suggested that there were no significant differences in oncologic outcomes, with local recurrence in this cohort and also recurrence-free survival. So breast conserving surgery is quite safe, and oncologically it's feasible to do it. How about the Japanese choice? So patients with BRCA mutation patients do prefer to have the mastectomy by 76%, but 23% of the patients chose breast conserving surgery. On the other hand, non-BRCA mutation carriers chose more breast conserving surgery at this era. So the choice is different, but breast conserving surgery is not a contraindication for those patients. Through looking into the thing, contralateral mastectomy without genetic risk, that is another trend in the United States. Contralateral prophylactic mastectomy, irrespective of genetic risk factors, is very common in the United States. That is what is told. In 2012, patients aged from 20 to 44, the contralateral mastectomy, prophylactic mastectomy was done in almost more than 30% of the patients. But we know that the contralateral prophylactic mastectomy at the average risk of the patient do not have any prognostic advantage. So the guidelines do not recommend contralateral prophylactic mastectomy for those without increased genetic risk, but there is a trend that in the United States. But this procedure is not covered by insurance in Japan, and I think it's not really popular anywhere in India or the other countries as well. In the United States report, why patients choose to have the prophylactic contralateral mastectomy regardless of the genetic risk. The patient most popular reason was the peace of the mind. So this is an area where surgeon communication strongly influences the patient decision. Contralateral prophylactic mastectomy in patients without increased genetic risk is not covered in our country, and it is not recommended by many guidelines. But it is popular in the United States, and the peace of the mind is very important for the patients. And of course, cosmetic symmetry was the next reason to do it. The surgeon involvement in decision making is associated with less aggressive treatment. So how about the future direction or survivorship issue? Breast conserving surgery or mastectomy or with reconstruction? Which one is the most high QOL procedure? The patient reported satisfaction with their breasts was similar 10 years after breast conserving treatment and radiation, with mastectomy with or without reconstruction. However, psychosocial and sexual well-being were better in patients treated with breast conserving surgery with radiation. So mastectomy with reconstruction is not always the best way to do it. So. The breast conserving surgery with quality of life, how is it different? When we start the treatment, like the time since diagnosis is listed on the bottom bar, and breast conserving surgery is somewhat, it's not really deteriorating. While QOL improves over time, young breast cancer survivors who undergo more extensive surgery, I mean like a bilateral bilateral mastectomy, have the worst body image, sexual health, and anxiety compared to women who undergo less extensive surgery, I mean like breast conserving surgery. How about the radiation? Radiation treatment is for the benefit of the radiation does not change from the time, the age. And there are a lot of de-escalation trials for axillary surgery or radiation. We have heard a little bit about that yesterday, but there are a lot of new coming data, and we have to wait for the others. And also, oncoplastic surgery is getting more common in everywhere. How about non-surgical ablation? We do have a radiofrequency ablation without excision of breast cancer in Japan. This trial called Raphael study was reported at ASCO 2024. So the RFA, we call it RFA, we stick the needle into the tumor and then we just give the heat. So it's over the 70 degrees. And then we don't do any surgery, but we do the radiation afterwards. The tumor has to be less than 1.5 centimeters, but national insurance coverage started in December 2023, and it's getting a little bit more popular in these days. And in this Raphael trial we treated over 300 patients, and there are only 2 local recurrences, so it's quite safe. And trials, omission of breast surgery after neoadjuvant chemotherapy is ongoing. And in Japan, we have the Amaterasu trial, which is done for the HER2-positive trial, HER2-positive cohort, and also active surveillance trials which omit the operation as well. In Japan, we have the Loretta trial, and it will be open at San Antonio this year, so next month. So in the final slide, young age is not an indication for mastectomy. The local therapy should reflect tumor biology, genetics, and patient values. Young women often receive more aggressive surgery despite equivalent oncologic safety of breast-conserving surgery. With modern adjuvant treatment and oncoplastic surgery, breast-conserving surgery remains oncologically safe and cosmetically empowering for appropriately selected younger patients. And de-escalation based on biology and precision reconstruction, less invasive technique can optimize both survival and QOL. And I would like to thank my patients as well. And also, as Dr. Kitano have mentioned, we have this conference next year in Japan. We may have the on-site and also online registration as well. So please keep in touch. Thank you very much.
Okay, so that was a very nice presentation. I just have a question. Ma'am, Dr. Hiroko, if you can hear me. I just have a question regarding the trial which you are doing, going for non-surgical methods in young patients with breast cancer. So where we are doing thermal ablation and radiofrequency ablation. So do you follow it up with adjuvant radiotherapy or just the local therapy for those patients?
Thank you very much for the question. For the radiofrequency ablation, it is not only for the younger generation, but it included younger generation as well, and which is very important. And for after RFA, we do the radiation, local radiation as well.
Okay.
Please, can I ask you one question as well? It's concerning the surgery of the axillary lymph nodes, because yesterday we had some different talks. Some people say we have to clear the axilla in young breast cancer patients, and actually I sort of advocated that it's not necessary anymore in all those patients. What's your opinion in Japan?
Personally, I was very convinced with your talk. I think the axillary nodal resection, after, if the patient had a clinical positive node before the neoadjuvant chemotherapy and after neoadjuvant chemotherapy, the response was really good. I would do the sentinel node biopsy and rely on that result. So I think I would prefer to have less surgery for axilla as well, because many young patients live longer, but if they have the lymphedema, it's really miserable.
Yeah. Okay.
Yeah, excellent talk. Just a question on the screening, not necessarily on the content that was presented. We are aware and we are told that, of course, in Japan, a lot of women have dense tissue, even above 45 years. You know, the studies show more than 60–70%. So do you use a different screening method, which probably is applicable even in young women? And just wanted to understand whether you screen high-risk young women. Thank you.
Thank you very much for the question again. We do have the national screening program, and for the AP, but it usually starts from the age at 40. So patients who are younger than that are not covered by the national screening program, but they are informed about the breast cancer risk, and the individual, based on the individual risk, they may have the ultrasound screening plus minus MRI screening on the genetic risk.
Even above 40, do you do only mammogram, because 70% of them have dense tissue?
At 40, starting from at 40, the mammogram biannual, but ultrasound can be done every year.
Thank you, Dr.
One more question.
Sorry,
yeah.
sorry.
I am Dr. Kunjari Medi. I am medical oncologist. So my question is, in a young 35-year-old female, triple negative breast cancer with family history, BRCA positive, do you recommend BCS in this type of cases? Because in one hand, we are recommending prophylactic mastectomy in this type of patients, but in other hand, do you recommend BCS in this type of patient?
Thank you very much. For that population, if the tumor is like more than 2 centimeters or something like that, we would prefer to do the neoadjuvant chemotherapy first. And then if there was a clinical complete response, then we we do not recommend mastectomy or BCS, but we do offer the option of mastectomy or BCS, and the patient's choice is very important in that situation.
Thank you. Thank you. So we'll conclude the session now, and I'll call upon for the panel discussion Dr. Shyam Agarwal, the chairperson of Department of Medical Oncology, Gangaram Hospital, and he'll conduct a panel on clinical decision making in young women with breast cancer, systemic treatment in HR positive patients. Dr. Shyam Agarwal. And I'll also call upon Dr. Indu Ambulkar, Director and Senior Consultant HCG Borivali, Mumbai. Dr. Ambulkar. Then Dr. Hiroko Bando once again. Dr. Hiroko, please come back to the stage. Dr. Nilakshi Mahanta, Professor and HOD Department of Medical Oncology, State Cancer Institute, Guwahati. And Dr. Kunjahari Mehdi, Senior Director, Department of Medical Oncology, Cancer Care, Medanta, Gurgaon. And Dr. Deepak Bharti, Senior Consultant, Department of Medical Oncology, Mata Vaishno Devi Narayan Super Speciality Hospital, Katra, Jammu. Dr. Deepak Bharti, please. Dr. Bando, please.
Indu is not there, right?
Indu is not there. Doesn't seem. Yeah. And
good morning, everyone, and welcome to this interesting panel discussion, hopefully. So many new things are happening in the field of ER positive breast cancer, and I spoke to Ashok, what do you want us to cover? So he said from early to metastatic disease, so let's see how far we can go. Can we have the slides, please? So we're going to, no, this is not my slide, I think, the other one. So, you know, this is a case-based panel discussion which we are going to have, and looking at the evolving areas of development. Right. So I think we deep dive with a case right away and take it, you know, as it, and we'll love to have involvement of the audience as well. So this is a 25-year-old lady who has a 2.5 centimeter invasive duct carcinoma and node negative, and this is poorly differentiated on histopathology. Ki67 is 10%, ERPR is strong positive, HER2/neu is 1+, there is no metastatic disease, and there is no family history, and patient has had BCS done, that is the breast conserving surgery. So this is the patient profile, right? So poorly differentiated, T2 and 0, and there is no evidence of metastatic disease. HER2/neu is 1+. So what next for this young lady? Should it be chemo? Should it be hormonal therapy? Of course, let's set aside radiation because she's had BCS, so radiation is certainly on. Or targeted therapy, or would you like to do any other investigation to make a decision as to what needs to be done for this lady? So Dr. Mehdi, what do you think for a 2.5 centimeter? It's not an uncommon scenario. I think we will see such patients in our day-to-day practice. Yeah.
2.5 centimeter tumor, this patient needs adjuvant chemotherapy, adjuvant radiotherapy, because BCS was done, and ER positive, we need adjuvant hormonal treatment also. But at the same time, I want to do the comprehensive gene panel also, family screening.
What is that comprehensive gene panel
that
like to do?
That includes all these panel, including BRCA1 and BRCA2, PALB2, all those.
So there is no family history, as I said, and Dr. Nilakshi, please. Would you like to do a CGP, I mean, as he's suggesting, or something else?
She's a young patient, and in any young patient, I would definitely want to know the BRCA status.
Okay.
So
BRCA is negative. Okay, let's say that, because there's no family history and BRCA is negative.
So with a 2.5 centimeter, she would definitely, she is a candidate for chemotherapy followed by hormonal therapy.
Okay, so chemo followed by hormonal therapy. Deepak, you agree or you want to do something else?
So it's only about the age which is guiding us to do for the chemotherapy. Because if same patient is same scenario is more than 50 or something like that, we all will go for the oncotype DX something like that. But
Yeah,
in this
we're talking
patient,
of young patient here who is node negative, 2.5 centimeter.
so definitely we'll go for chemotherapy. and
Chemotherapy. Dr. Hiroko, please.
Was she checked for the P53 mutation status?
So you want to check for P53?
Yes, it's young, of course.
Okay,
it's
so
not a
that's
process.
negative.
Okay.
BRCA is negative. So, but I mean, are we going to go for that panel? That is the question. Anybody is doing, comprehensive gene profiling in upfront in a patient who is T2N0? Dr. Warrior? No. So anything else before I move to the audience, Dr. Hiroko? Anything else you want to do?
In this situation in Japan, I would consider doing the Oncotype DX.
Right. So, any takers for Oncotype DX? Because Deepak?
No, not in our scenario, not in this age. We are secondary more than 50 years only.
Okay. Anybody else in the audience wants to make a comment on any kind of panel or Oncotype DX? Dr. Seema, would you? Yeah. Before Dr. Kataria says Oncotype. Dr. Seema, your thoughts? You will not. So gene testing means your BRCA 1, 2. How would that influence your treatment if it is positive? Right. So what's the? I mean, why should we do it? I mean, it's of course an expensive test if you are doing a comprehensive gene profiling. So in a HR positive who is node negative, so I mean you can do it because she's a young lady, but we thought this patient underwent Oncotype DX and the score is 14. So what do we do next for this lady then? So this is a low score because less than 15 or less than 16. So how do you treat this patient? So this means that the risk recurrence score is low. So Dr. Hiroko, what would you do now?
For this patient, maybe if we have to check whether she needs for the fertility preservation or not, but as for the treatment, I would do the LHRH agonist and the tamoxifen.
Right. So Dr. Nilakshi, your thoughts on fertility preservation. We're going to come to that issue also, but then this lady is not going through chemo, Dr. Hiroko, because the oncotype score is low.
Yes, maybe it is not a absolute indication for the chemotherapy.
Right. So
and despite the low Oncotype DX, I would look at the clinical criteria here where the T size is 2.5 and also the poorly differentiated, and
right.
the Ki67 also would matter. So I would put
so
those
that's
criteria.
10%. Ki67 is 10%.
10%. Okay,
and
but the
it's
poorly
differentiated
and the T size.
Right. So what next for this lady? So people are still on for chemotherapy in spite of low Oncotype DX. Dr. Tari, what do you think? But the risk score is low. Say it is 10, 11. So would you avoid chemo? That is the question. Okay, so you would give the choice to the patient rather than giving chemo to all. Dr. Medhi, what do you think? With a low score, T2N0, poorly differentiated.
I am not confident to avoid chemotherapy.
Okay. So as per the guidelines of 2024 NCCN, if the risk score is less than 15 in a premenopausal T2N0, you can avoid chemo. So that's the guideline as it stands here, right? So what else can we do? No, but you're following the guideline. Why would you like to subject a patient to chemo? And the other issue was regarding the fertility preservation, which Dr. Hiroko very rightly raised. So if you are not doing chemo, would you still like to do the fertility preservation for this lady?
For this lady, maybe we do the hormone only, but it can be 10 years of the longest. So then at the time of 35, maybe it's not really, good age for the pregnancy.
Okay, so that's very interesting point. So you would give the hormonal therapy for 10 years before you allow her to become pregnant.
The positive trial is quite one of the things that we can recommend.
So we were coming to that only. So with this lady, any other choice which we have in terms of targeted therapy? Let me put a direct question. Is there a role for CDK4/6 inhibition in this lady? Dr. Hiroko.
role for CD, no, I wouldn't do that. It's out of the eligibility criteria for the MONARCH trial. So you mean abemaciclib?
No,
or
what
the-
about the NATALEE study? What about ribociclib?
Oh, in Japan, we don't have the ribociclib. So we can only use abemaciclib, so based on the MONARCH E trial.
So, Dr. Medhi, any takers for NATALEE study? You see the inclusion criteria here. So, if you had T2N0, if you see that orange bar, so grade 3 or grade 2 with Ki67 more than 20% or high genomic risk. So, this patient is grade 3 and T2N0. So, it fulfills the criteria for NATALEE. Dr. Medhi.
So it fulfills the criteria.
I mean, I know these are areas which are evolving. So there could be a lot of debate and discussion on whether to use ribociclib in this lady or not. But then that's what we are discussing here.
Sir, in this type of cases, I would like to discuss this aspect with the patient in detail, because the complication and side effects of CDK4/6 inhibitors is there, and what is the amount of benefit and in comparison to amount of
So
side effects.
this is the IDFS data by nodal status. Even if you have N0, you see there is a 5% benefit. The delta is 5% for IDFS, and similar for N1 to N3. So as per NATALEE data, this patient with T2N0 grade 3 fulfills the criteria for NATALEE study, and therefore what you're trying to do is you're trying to avoid chemo by adding CDK4/6 inhibitor in this individual. So you'd like to have comments, Dr. Nilakshi or anybody in the audience.
So I think that was a very small subset in NATALEE, and these are very evolving times now. So to straight away jump into this conclusion for a 25-year-old who has her whole life ahead of her, and to avoid chemo, I would probably want to take some more time and discuss the options with the patient.
Okay, so the thought process is whether or not we can avoid chemo in such individuals who are ER positive and fulfill the criteria for NATALEE study.
Because,
yeah.
Yes, sir. These are actually evolving discussion, but
the panel discussion is meant for
yes,
creating that thought process that yes, we are moving to that direction.
Yes, sir. All these things we can discuss, because we are avoiding chemotherapy and we are going towards hormonal therapy and CDK4/6 inhibitor, and these data are evolving and yet to be, we have more and more experience.
So you have the NCCN guideline for NATALEE study, I think. Dr. Seema, you agree? Or you still want to go? They all want to go for chemo. So I want to take you away from chemo. You will not. Why is that? But once it is, the NAT and the benefit is there for node negative. This patient is what? Can you have a mic? Can somebody give her the mic, please?
So this
the genomic score.
Genomic score is 14, which is not high risk.
Right.
Her Ki67 is 10%,
Right.
which is not more than 20%. So she is not actually fulfilling the NATALEE criteria.
No, she is. She is. That's why I showed you the slides. See this. Grade 3 alone is sufficient. Or it has to be grade 2 with your genomic score high or Ki67 more than 20%. So grade 3 alone is sufficient for the inclusion in the NATALEE study. You don't need the other parameters like oncotype DX and Ki67.
So, but if we look at the number of patients who are node
Right,
negative
that's
versus
a
node
separate
positive,
issue, right.
and there is no oral survival benefit.
So Dr.
given
Hiroko, what do
till
you
date.
think? I mean, if you were given the choice with this study, would you avoid chemo in this patient?
If we can use the ribociclib, then I would like to prescribe her. Or in Japan, we have another trial of the S1, 1 year S1, which is potent trial. So that's another candidate for this lady as well. So if we can add and avoid the IV chemo and do something else, that would be a really good candidate for her.
Right. So I think it's food for thought to have a call on patients who have early breast cancer, maybe node negative, and see whether this patient is fit to avoid chemo or to just add, a drug like ribociclib. So I think Dr. Hiroko mentioned about the, the soft and the text study, and in which, and that's the study design here, where the OFS was used, and this is a 25-year-old lady, as we said. And let's say we preserved the ovaries, I mean the fertility preservation is done before starting the treatment, yeah.
Maybe it's not really necessary, but we discuss.
Absolutely. So I think, but then we did that because patient says, I don't want to take any risk because it may not sort of come back, the periods and all. So this is update here, recent update on soft and text, in which, you see here 4,690 patients were included. And there is a significant overall survival improvement in women who are less than 35 years, who have a tumor more than 2 centimeter, and patients who have a grade 3 tumor. So this patient actually fulfills all those 3 criteria and therefore becomes a candidate for OFS and aromatase inhibition. So I think we can move on, and this is something which is very, very new, which is evolving. That is the understanding of ctDNA dynamics and IDFS outcomes in the MONARCH E study. Would anybody like to comment on this? Because this is very, very theoretical and research oriented at this point in time, but then that can also help us in deciding what treatment we should be giving. Any comments, Dr. Hiroko?
Well, it's a very interesting data,
Yes.
but in a really everyday practice, it's really still not easy to do it. So when to monitor the ctDNA is not really set, so we can't do it in everyday practice, but it's a promising data.
Right, so I think we need to keep an eye on this data which is evolving for baseline ctDNA detection, which means that when you're going to give the treatment, you're going to follow up and see whether the ctDNA is disappearing with the adjuvant therapy which you are giving. But that's very, very interesting, fascinating, and I think in the next 5-10 years, you'll be required to do this. So be prepared, and let's be looking at the ctDNA detection as to how it can be done, which labs can do it, and maybe it's a research point at this junction. So I think let's move on with the case. And so this patient was given GnRH analog, letrozole, and ribociclib. Okay, so this is maybe a theoretical case, but this was, and now the patient says she wants to have a baby. So how to approach? Dr. Deepak, what do you think? Can we allow this lady pregnancies? This is T2 and 0 and on 3 drugs.
So we can, but obviously when this point has come up, we have discussed that on very first day with the patient also. And obviously we minimum want to give the patient.
So when would you allow her to bear a child?
At the max minimum 2 years, I want to give the treatment, and then I will start the things on that.
Dr. Mahanta, please.
We can counsel her because she's 25. So if she completes 3 years of her treatment at least, ribociclib would be completed, and after that we can ask her to plan the treatment.
Dr. Medhi, you agree?
Sir, preferably I would wait for 5 years at least.
5 years.
Yes.
Okay, you want to complete the soft or the text. Dr. Hiroko, you were mentioning about 10 years. So should it be 10 years? Should it be 3 years? Should it be 5 years? Are there any guidelines there?
It could be 3 years after ribociclib.
Right.
It's feasible.
Right. So one can, so that's the study which I think Dr. Hiroko was mentioning. That is the positive study published in NEJM 2023 for, women attempting pregnancy. And as you can see, there were 516 women, and the median interval between the, hormone therapy was 18 to 30 months. So that was the time period which was allowed. And you can see 74% pregnancy rate with 63.8% live birth rate, and the 3-year incidence of breast cancer events was no different from patients who continued versus who were allowed to have pregnancy, 9.2% versus 8.9%. So therefore, in a young woman, after 2 to 3 years of hormonal therapy, one can allow for the lady to become pregnant. So this lady had a childbirth. She continued on GnRH analog and letrozole. So how long should that be? That's another big question, Dr. Medhi. So these are all very practical, pertinent points which we see in our day-to-day practice. In a lady who is 25 years, T2 and 0, how long to give GnRH analog and the AI?
The same question I asked yesterday in another session.
Right, okay.
But till when
So you are
we should
wiser.
continue GnRH analog? The consensus yesterday was, I think it was 5 years.
Yeah, the soft and the text says 5 years. So, Dr. Hiroko, would you stop treatment at 5 years or?
5 years, stop the LHRH agonist, but the tamoxifen for 10 years, I would say.
Okay, so, but then you'll have to continue GnRH for also 10 years?
No, the GnRH for 5 years.
And then?
Tamoxifen alone.
Okay, so after, stopping letrozole, you'll switch from letrozole to tamoxifen for 5 years. So I think that's a fair thought because you need the GnRH for letrozole to work and therefore, or exemestane to work and therefore. So, okay, so this patient then moves on and you give her a GnRH and the letrozole for 2 years, and patient now develops, I think there's a she develops skeletal lesions. There are mild symptoms. She's well preserved, and the biopsy confirms the same, which is ERPR positive and HER2 1+, right? 1+. That's what we said. So, what do we do with this lady who is on GnRH analog and letrozole? So, do we do some targeted therapy, chemo, hormone, or you want any more tests to be done at this point in time to decide what to do for such a lady? She is well preserved, she is good. There are like 5 or 6 bone lesions. Dr. Deepak?
So, as the patient is asymptomatic for the bones, obviously we not treat for local sites and we just go with the, either we shift to the hormone treatment from CDK4 to AI to any other one.
So she's just on letrozole and GnRH, and the ribociclib was stopped at 3 years.
And obviously the patient has not received chemotherapy prior to that.
Yes, of course. No chemotherapy ever.
So we can treat the patient with the chemotherapy at this point of time.
So you like to give chemo. So Dr. Medhi, you agree?
Sir, before chemo, I would like to
or any more tests to be done?
I need to see the ESR1 mutation now.
Okay. So you want to see the PIK3C?
Yes, sir.
Yeah. So that is negative. ESR1 is negative, and BRCA1/2 we already said is negative. So this patient is on letrozole. So what percentage of patients we expect the ESR1 to be positive?
I think it is less than 10%.
The patient is on letrozole for almost 5 years. Dr. Hiroko?
A little bit more higher than that.
But 20-25%. So almost 1/4 of the patients will be ESR positive. So, okay, whether it is positive or negative, does it change your treatment? Let's say ESR is positive. Dr. Hiroko, what do you think?
In our country, we cannot still use the oral third, but if ESR1 is negative or positive, then I would use the fulvestrant at this point with abemaciclib.
If the ESR1 is negative, then
maybe another aromatase inhibitor, but in this situation, I would prefer to use a fulvestrant.
Right. Dr. Nilakshi?
I would also consider switching the hormone because she's already got letrozole, so I would switch to fulvestrant.
Along with?
With CDK4/6, but maybe change to Abema.
Yeah, so, Ribo was given 2 years before. So she's not on Ribo for almost 2 years. She's only on letrozole and GnRH.
Yeah.
So you'll like to give fulvestrant.
With CDK4/6.
Yeah. So, Dr. Hiroko, do you have these newer oral drugs, SERDs, available in Japan?
We are expecting it maybe in 1 or 2 months, but not yet.
We don't have. So I think irrespective of ESR1, whether it is positive or negative, the treatment is going to revolve around hormonal therapy, which is fulvestrant and abemaciclib. So that's what was given to her, and that's the data for Abema, which is post-MONARCH, even after having been on CDK4/6 inhibitor, and you can see the progression-free survival, which is hazard ratio is 0.55. So this patient was given Abema and fulvestrant, and we said the patient is ESR1 negative. So are we doing liquid biopsies for ESR1 today? Any one of us? Dr. Medhi?
Yes, sir.
So you are?
Yes, sir.
And if this patient, say, 6 months down the line or 1 year down the line becomes ESR1 positive on Abema and fulvestrant, so would that change the treatment? How does that help then? We are asking for a test which is going to be expensive. Does it modify your treatment somehow?
If ESR1 positive, at least we know that this is AI sensitivity is less. So anyway, we will not consider AI. And abemaciclib is still indicated even in ESR1 positive. But one thing already clear that AI is not indicated. And already patient is on fulvestrant, then if it is positive, then there is a role of new SERD.
Right. So Dr. Hiroko, any thoughts on the SERENA-6? If the ESR1 becomes positive and the patient is asymptomatic, there's no progression of disease on radiologically and clinically. Patient is fine.
Well, elacestrant is not covered yet, but imlunestrant will be covered soon, so that's the choice.
So that's another important area which we need to keep in mind, that serial following up of ESR1 while the patient is on treatment can help us change our treatment to these new drugs which unfortunately are not available in our country at this point in time. So camizestrant, so you're basing the treatment on liquid biopsy, not on radiology, not on symptoms. Just when the ESR1 is becoming positive, you want to add a more potent SERD or a more potent camizestrant. So I think that, and this is a positive trial. This is a positive trial, and that's why it is becoming incorporated in the algorithm. So therefore, ctDNA to begin with, and then a liquid biopsy in metastatic disease. So what I'm trying to say is that liquid biopsies are going to be in the management of these patients, whether they're early breast cancer, whether they're metastatic disease. So, we really need to upgrade ourselves. So these are the other drugs for the SERDs, which we don't have, and therefore I'll not, venture into this. Okay. So the other question is, the issue is that we don't have these newer drugs other than alpelisib, which we all know, because we don't have the AKT4 inhibitor. Of course, we do have the other agents. I think so. This patient, actually, we missed the slide. So after 2 years, she develops now lung and bone lesions. So she's on fulvestrant and abemaciclib. So what do you do then, for such a patient? So patient is on abema, fulvestrant. Dr. Mehdi, where do we go? So these are some of the options which I've mentioned here.
So if the newer SERD is available,
that's not available.
That is the option. Then now I think patient is a suitable candidate for chemotherapy.
For chemotherapy. Dr. Deepak, you agree? So patient has had 2 lines of hormone therapy. It was ribo, and then of course this, and there was letrozole. So
we are talking about lung and liver mets.
Yes.
Obviously, visceral crisis or visceral disease is on. So we have to give chemotherapy at this point of time, definitely.
Chemotherapy.
Yes.
Dr. Nilakshi?
I'd like to do a biopsy from the lung or liver again to again see the.
Okay, it's maintained.
If
the
it's
same.
maintained,
Yeah.
but the HER2 also you said
Maintained.
it was 2+.
HER2 is 1+.
1+. Since she's chemo-naive and we have visceral mets, then chemotherapy is the first option. But we do have some more things in line, probably at a later stage.
Dr. Hiroko?
If the patient is still very healthy or fit,
Yes.
then I may think about the capivasertib or afinitor and everolimus at the third line hormonal treatment, and then maybe trastuzumab deruxtecan.
Right. So I think the question was whether to give chemo or you can switch to HER2-directed therapy, which is Enhertu. So I think Destiny 6 is there now, in which you fail 2 lines of hormonal therapy, then this is low, HER2 low. So TDXD is better than chemotherapy. You agree, Dr. Hiroko? Yes. Right. So, we've come almost 6, 7, 8 years, and we're not talking about chemotherapy. So that's how the science is, growing in the last, several years, that we can still avoid chemotherapy, although TDXD is also refined chemo. It's not that it's not chemo. It does have all the side effects of chemo, for example, hair loss, nausea, vomiting, and pancytopenia, etc. But, these are the issues as they stand are evolving. And you still have drugs like sacituzumab. You have sacituzumab govitecan in Japan.
We do.
So how is your experience with this drug?
This drug is only at the moment used for the triple-negative breast cancer, sacituzumab. But the TROP2, DXD, Trodelvy is also possible for us to use.
Right. So I think, so these are some of the guidelines, as you can see here. So we are actually getting spoiled, and we have not spoken about chemotherapy at all, where we have at least 10 to 15 drugs which can be used in a sequential fashion for these patients, depending upon the patient's condition and the the status, the ECOG status. So I think that's how the protocols are evolving at this point in time, and you have to keep in mind several issues, including the changing behavior of the disease, because as Dr. Nilakshi pointed out, I mean, patients can become ERPR negative, although little less, but then 15-20%, and that's why repeat biopsy is required. And similarly, HER2 is also a changing, over a period of time, because, for example, we had a patient who was 1+, 3 years down the line became 2+, and 3 years down the line she became 3+. At that time, we only had the approval for Enhertu for 3+. Now you have the approval for HER2 low or even ultra low, after we have failed chemo or 2 lines of hormonal therapy. So I think things are really changing for the good, and these patients are living a fairly long and a good quality of life. And we have to discuss fertility preservation and the CDK4/6 inhibitors. And everolimus was mentioned. We should not miss that, because that's another option before we switch to chemo or more aggressive treatments. So is there any question from the audience? We are still here. Yes, Dr. Seema.
When this patient relapsed on aromatase inhibitor and GnRH analog, she had only bone mets.
Skeletal mets,
so
yes.
anybody would prefer the SONIA trial approach, where CDK4/6 inhibitor, whether used in first line or second line, overall survival was same. So would anybody will give her only fulvestrant and not add CDK4/6 inhibitor when she has only 4 or 5 bone metastasis, no visceral metastasis?
Anybody wants to take this?
I think at present only fulvestrant, instead of giving only fulvestrant CDK4/6 inhibitor, at least abemaciclib is, I think, strongly indicated in this type of situation.
Yeah, this is a fit young patient, so why should we kind of deprive her from CDK4/6, because very well tolerated. Had the patient been old, 75, 80, unfit with a lot of comorbidities, there you can think of doing a fulvestrant alone and perhaps not adding a CDK4/6. Dr. Hiroko, your thoughts?
Yeah, you mentioned about the SONIA trial. It's a very interesting concept, but still, for this patient, she had metastasis while on the hormonal treatment. So biologically, it's a second-line treatment. So I would go for the abemaciclib product.
Right. So I think we had a fairly good discussion on HR positive, the entire spectrum of the disease, how the things are evolving at this point in time. So we are thankful to all our panelists here, and thanks to the audience for an interactive discussion. Thank you very much.
Thank you so much for such an insightful discussion on hormonal positive breast cancer. Next, I would like to call Dr. Dhanbir Thanjam. He's a consultant from Imphal for the panel discussion on treatment approaches in HER2 new positive and triple negative breast cancer.
Good morning, everyone, and thank you, the organizing team, for giving me the opportunity. I am Dr. Dhanbir Thanjam. I am a surgical oncologist. I work in this hospital in Imphal. I got this information a bit late, so my preparation is not that fully prepared. So let's see. I'd like to call our excellent panelists. First, Dr. Seema Gulia, Dr. Hiroko Bando, Dr. N.K. Warrior, Dr. S.P. Kataria, Dr. Rajib Seni, Dr. Ankul Mudgal, and Dr. Nadim. It's full of medical oncologists and one surgical oncologist. Okay. So I have two cases, one HER2 positive and one is triple negative. Please, next slide please. Okay. The first case, she is a 40 years woman. She is a school teacher by occupation and had 3 years old children. No family history of ovarian or breast cancer. The on examination right breast lump of 4 into 3 centimeter at 3 o'clock to 4 o'clock. This is 2 centimeter away from the nipple and the breast size is of cup B. An axillary lymph node is noted on the same side around 1 centimeter. Core biopsy is IDC grade 2. Axillary lymph node is FNAC proven metastatic disease. Is a HER2, ER and PR positive. HER2 is IC positive, 3 plus. KI is around 45%. PET scan was done, being a not positive, no sign of any distant metastasis. So the clinical diagnosis is HER2 positive, hormone positive, T2N1 M0. This is a common question for everyone. Anyone can answer. Any insight on low HER2 and ultra low HER2? If I can give the question to Sima ma'am.
So this patient is HER2 3 plus.
HER2
So
3
she's
plus.
clearly HER2 positive.
Yes.
Low HER2 is when it is 1 plus or 2 plus. Ultra low when there is faintly some staining is done where they can't even define it as 1 plus. That is ultra low.
So will anybody go for an upfront surgery or an, I think patient will follow NHT. So
in a HER2 positive disease, we'll consider for neoadjuvant chemotherapy plus targeted therapy.
Okay.
That is a TCHP approach, which has shown the benefit in many trials. That is Newsphere, Trapina, TRAIN trial.
Okay, fine. So my question to has already answered. The preferred regimen for neoadjuvant regimen is a chemotherapy and HER2 directed therapy. How long will give this?
The combination of docetaxel, carboplatin, trastuzumab, pertuzumab given once in 3 weeks for around 6 cycles followed by a surgery.
Okay, fine. So it's a 6 cycle. So the question to the surgical oncologist, ma'am, will you put a breast tissue marker, and if yes, when you will place the marker? Because it is around 4 centimeter near the nipple. To Madam Hiroko.
I would put the clip maybe at the beginning, but if it was not possible, then maybe at the 2 or 3 cycle when the tumor started to shrink, then I would just keep the clip
In
on.
this particular patient, is it 4 centimeter, hormone positive, HER2 positive?
It depends on the shape of the tumor, but usually even the tumor size is 4.5 centimeters, it shrinks very well, and then it's maybe possible for the breast conserving surgery afterwards. So I would
So
do it.
you will press in the beginning.
Yes, if it's possible, beginning.
So patient has a good response. So after giving the NHT, will you do an imaging to decide the surgery? Any more imaging to decide the surgery for this patient?
I would usually do the ultrasound and MRI and the CT scan for before the surgery, before the neck and after the neoadjuvant chemotherapy, just before the surgery.
For all the patients, you will do MRI before the surgery. And your experience and SLNB in and after NHT, you will still do SLNB in this case, this patient after neoadjuvant chemotherapy?
I would do that if the tumor shrinkage is really good, and then if you can see the enlarged lymph node, then I would go for the sentinel lymph node biopsy.
So, what is the option of oncoplastic approach in this patient to Madam Hiroko?
Thank you very much. If the patient is candidate for the breast conservation surgery, then it's possible, and we may do some of the tissue moving for the oncoplastic surgery technique. But if the tumor is it's very risky to do the breast conservation surgery, then nipple-sparing mastectomy can be another candidate with the reconstruction.
Ma'am, do you practice chest wall perforator in Japan? Chest wall perforator flaps. Chest wall perforator flaps.
Chest wall.
Chest wall perforator flaps like
chest wall flaps. Yes, it's possible. Yes, it is.
You practice.
Yes, and together with the plastic surgeons.
Okay. Fine. As you have already mentioned about mastectomy and reconstruction in Japan in your previous talk, so I will skip the question. So after the surgery, this is the final biopsy report. Residual disease is there. IDC the grade remains same. There is some definite response to pre-surgical therapy. The tumor sizes become 1, lymph node is 0. We have done an axillary lymph node dissection, and it's a YPT 1B and 0, and residual cancer burden is 1.5 and class 2. So the medical oncologist, Dr. Kataria. Anybody can take up. So will you do a retesting after NSCT? Means all the ISC will be repeated?
No, it's,
no. Okay.
It's already there. We have a histopathology report. It's already done. I think
No,
we'll
I
go
mean
with
like
the first report itself.
ISC, will you repeat again or no?
Not necessary.
Not necessary. Fine. So adjuvant therapy based on the response. So this patient has a pathological response, supposing a very good pathological response to Dr. Warrior.
Yeah, if it's a pathological complete response,
yes,
then probably we will continue with the same regimen, the same dual anti-HER2. But in so she had residual disease. But
no, I'm just asking if there is a complete.
Okay, yeah. So if it's a complete pathological response, I would like to continue the dual anti-HER2. But when the resources are limited, I will certainly limit it to one, that is trastuzumab. The rest of the cycles will be trastuzumab alone.
Okay. So I think this is the continue trastuzumab and trastuzumab for 1 year.
Yeah.
Everybody is agreed. Any opinion on this? Fine.
If patient has complete pathological response, then we, because it is early stage, we can drop pertuzumab and we can continue with trastuzumab. But if upfront disease was heavily node positive, then we can combine trastuzumab and pertuzumab. Otherwise, in this setting, we can very well drop pertuzumab.
Okay. So if you seeing according to the previous
pre-operative staging.
Fine. That's fair enough.
We had an excellent response to neoadjuvant, so I think we should continue.
Okay.
Dual therapy for.
Only thing is, you said initially the Ki-67 was high.
Yeah, 45.
So yeah, 40.
So for this patient actually, and anybody has an experience on using subcutaneous trastuzumab and trastuzumab in India?
Yes, that can be equally
interchangeable. I think they can be used.
How convenient is for the patient for this subcutaneous?
Obviously, except the cost, I think it's good.
Is except the cost. Madam Gulia, any from experience in Tata using this?
Yeah, we are using this subcutaneous trastuzumab and pertuzumab in both adjuvant as well as in metastatic setting. And patient really love this because they don't have to spend hours in the hospital and in the daycare. They just come and take the injection and go back home in 10 to 15 minutes.
Okay, fine. So this patient has a residual disease. So TDM1, how long and how this will be helpful?
So 14 cycles of TDM1 that is to be given because she has residual disease.
14 cycles. Okay. So, and any opinion on this? Any different opinion on this?
This is the currently standard of care everywhere. I mean,
Okay, fine.
Is
This
it
is the
something I
standard care Captain trial. So, anybody has used neratinib in non-metastatic setting with a residual disease?
I have not used neratinib because it is not available in India.
Mm.
But neratinib can be used in patients who are hormone receptor positive along with HER2 positive. Only in that subgroup the benefit was
Yeah,
seen.
this is hormone positive, HER2 positive.
Yeah.
So, is it can be used in non-metastatic setting too?
But the toxicity was too much. I mean, diarrhea was very troubling.
Significant.
Okay. Toxicity is the issue. Okay. Fine. There is no radiation oncologist, but this I want to put a question like integration of timing of the radiation therapy along with trastuzumab.
It can be given
Along with,
concurrently.
okay. Fine.
Even with the TDM1, it's safe.
Okay.
During the radiation, you can give.
So radiation is safe during trastuzumab and TDM1. So how do you do the cardiac monitoring during therapy? Is it
So we do cardiac monitoring every 3 monthly. We do the
every
2D echo.
Every 2D echo.
Or if the patient is symptomatic, then earlier. Otherwise, every 3 months it is mandatory.
Okay. So 3 monthly cardiac monitoring is important. So fertility preserving, this lady has only one.
Offering GnRH analog to start before starting the treatment, and will continue during the course of treatment, so that fertility can be restored after the treatment.
Okay. This is the algorithm. I will not go in the details. So I have this is second case. He's quite young. This patient is 30 years. She worked in a bank and is 2 children. She had a family history of mother has an ovarian cancer at around 56 years, around 60. She has a breast lump around 4 centimeter at 10 o'clock to 11 o'clock with an axillary lymph node positive, and the skin and the nipple are not involved. The T2N1 M0 core biopsy grade 3 IDC is a hormone negative. HER2 ISC2 plus FISH not amplified, so it's HER2 negative, Ki 80%. We did an MRI and there is no contralateral disease and there is no multifocal disease on the same side. PET scan, no sign of any metastatic disease, is a triple negative T2N1 M0 clinically. Regarding this patient, will you be offering this PD-L1 testing before the start of the treatment?
So
Madam?
PD-L1 testing.
Hmm.
So PD-L1 testing is not essentially done in a neoadjuvant setting. We are
Mhm.
preferring. It is irrespective of the PD-L1 status we plan for. If the patient is affordable
Okay.
enough, we can plan for pembro plus chemotherapy according to Keynote 522 trial.
Mhm.
So for that, PD-L1 testing is not required.
Not required at the beginning.
Not mandatory for the neoadjuvant treatment, but it should be for
In the
metastatic.
metastatic setting. So BRCA was done in this patient. She is BRCA negative. Already, can somebody describe a little bit on this neoadjuvant chemotherapy regime of this patient, triple negative T2N10? Yes, doctor.
She's a young
Young.
female. I mean, we can offer her dose dense along with the immunotherapy.
Mm.
So in dose dense, we can give adriamycin cyclophosphamide followed by taxanes with this pembrolizumab.
Any different
And then
opinion?
Carboplatin can be added to taxane to improve the pathological complete response.
So the approved regime is 3 weekly AC with pembrolizumab, 4 cycle of pembrolizumab, followed by 3 weekly pembrolizumab with paclitaxel and carboplatin. This is the what guidelines recommend.
Okay.
Here is a young patient, being young, and the carboplatin will make all the difference, if at all, by in the sequencing.
Yeah, normally we'll start with taxane plus carboplatin plus pembro 3 weekly, followed by 3 weekly AC plus pembro.
I think all the panelists is agreed with this.
Yeah.
So it has a better pathological response rate adding carboplatin. So this is the Keynote 522 trial for the surgeon, madam. Hiroko ma'am. This is the patient. Unfortunately, patient on 4th cycle of chemotherapy NSCT, the response is not good actually. So this, in spite of a good HER2, triple negative and good KI, the patient has not a good response. He's a young patient and is in the upper inner quadrant, difficult for most surgeon. So already clipping we have discussed. Ma'am, in this patient, how you will approach for a breast conservation surgery? Because this is the area where there is the reconstruction is quite difficult for this patient. What type of reconstruction you will do in this patient?
This place is very difficult, even for the implant, or it's not really fit. So maybe we do a little bit wider reduction followed by the lateral dorsal muscle augment implant. Or it's not an implant, but it's reconstruction.
Ma'am, in this patient we did a matrix rotation flap. I'm not showing. So already discussed about SLNB in a post-energy setting. Ma'am, sometimes patient has a heterogeneous response. So as you told that you will do an MRI. The heterogeneous response means like the tumor is reduced in some part and it is not reduced in other part. So is it still okay? We do a breast conservation surgery in heterogeneous response.
For this patient, if the tumor shrinkage is not obvious in the breast and also in the lymph nodes, maybe we can consider about the fine needle aspiration cytology for the lymph node, but usually I would go for the axial resection for the patient.
Okay. So I did the same. We did a breast conservation surgery with a rotation flap and axillary lymph node dissection. This is the residual disease grade 3 with no definite response to the pre-surgical therapy. The tumor remains almost same and margins were clear. One lymph node was positive, R of 26, so YPT2N1A, so RCB class 3. To Dr. Warrior.
Here we have residual disease. So, if you in this particular situation, we would like to add capecitabine, put her on capecitabine 6 to 8 cycles, so that 6 months of continuous oral chemotherapy post surgery.
Any difference in opinion?
We'll continue the immunotherapy in the adjuvant setting. Okay. Along with that, capecitabine can be added, and this is as per the JEPA-DUCE trial have added capecitabine along with immunotherapy. So it is a feasible option.
Okay. So adjuvant capecitabine as a grade X trial. I think everyone is agreed with this. So we'll just move to this. So supposing this patient, for this patient is BRCA negative. In case is BRCA means pathogenic mutation is positive, then what is the difference in the treatment?
And we'll plan for basically olaparib as per Olympia trial for 1 year.
For 1 year, okay. Yes, please.
Olaparib, but when? Before capecitabine or after capecitabine?
So there is no, we will not use capecitabine.
So
I think it's not yet clear. I mean,
so there is no head-on trial, but it's very difficult to combine them, or if the sequencing is also very difficult.
The combination is extremely difficult. So yeah, so it's basically capecitabine will get the upper hand, and generally we follow. We will add olaparib or PARP inhibitor after capecitabine. It will be continued for 2 years.
We don't want
Anybody?
Interruption we don't want. What do we say?
Dr. Rajib, anything?
So, see, in Olympia trial, the amount of quantum of benefit is more with the olaparib rather than capecitabine. So, if we have to give one, then we should give olaparib. But if we want to try both, then we have to give sequentially. First, complete capecitabine, and then we can continue olaparib for 1 year.
Okay. Thank you. So,
capecitabine also it's a very
sorry?
large disease. I didn't respond well. So capecitabine has to be continued. That is more important in adjuvant setting.
will you do multi-gene panel testing in triple negative young woman in such with for the family history of a mother and ovarian malignancy? EPS?
Broad panel can be done
A broad
because
panel.
the patient has a strong family history. And secondly, if we are doing a BRCA1 and 2 testing only with NGS, then MLPA can be added
Okay.
to get an additional. Sometimes some large deletions can be based on NGS testing. So that is what we can do additional.
Yes, thank you. Madam Hiroko, how do you manage such patient in Japan regarding their psychological and family support, because she is a young woman?
Yes, in Japan, it of course depends on the which area if she is in Tokyo or big city or the other one. But usually in Japan, I'm a surgical oncologist, but I do the chemo for those patients as well. So all the cares will be managed by the breast surgical oncologist, I would say, and also nurses and also psychosocial support team, and sometimes if the patient is really depressive, the psychologist, psychiatrist, all the team practice is very important for those patients.
Is before the beginning of the treatment?
Of course, we do assess before the treatment, but during the treatment, we have to keep following them, following this lady. Yes.
Madam Sima, how is it in TMC, TMI's Mumbai for such patient, young patient, like psychological and family support?
So we have
counseling?
a psycho-oncology department where we do send them for counseling, and they do repeated counseling with them even when pre-surgery, post-surgery, before starting chemotherapy, and even during the OPD visits. If we feel that this patient needs more counseling, then we do refer them on individual basis.
Okay. Yes. Anybody?
It's almost the same. We do have a psycho-oncology department and also genetic counseling department, where I think the BRCA1 and 2 alone will not be sufficient, so you have to do a broader panel. And accordingly, the patient requires both the counseling, like the psychological as well as the genetic counseling for further management.
We also have 2 units. We have a dedicated psychologist also in department. They see every patient in the daycare whenever they come. And I think broad-based gene panel, we are not doing it upfront. We are doing it at first relapse most of the time.
Okay. From Dr. Ankur, like regarding the lifestyle guidance and survivor care, because this is mainly for young women. So any insight on this for lifestyle guidance and
Always
survivor
advise
care?
patients to remain active, do some exercise, mainly walking, maybe 25-30 minutes in a day, to maintain a good healthy lifestyle. You can do yoga, you can meditate. So we always push the patients towards these habits.
Madam Hiroko, how is it different in Japan? Okay, ma'am, you can.
So I wanted to add one point that
Yes,
I
ma'am.
do advise my patients that weight reduction is very important, because it has been seen in trials also that patient who gain weight after completion of therapy, they are
Yes.
more likely to have higher recurrences.
Yeah, yeah.
So I stress upon weight reduction and maintaining an ideal body weight as much as possible.
Yeah, it is true. I have also seen patient feels after chemotherapy, after treatment, they feel the appetite is good, they start eating more, and the weight is increased.
Usually those patients who are on chemotherapy, they come to the hospital, but after it's over, they go back to the family practice or local clinics. So we have to have a close relationship with those local practice familiar doctors, and then just keep reminding them to live healthy and nicely.
Okay.
Slightly different in India. Patients whom we have given the treatment, they will keep coming to us for follow-up.
Yes, yes, it is in it happens in India. So thank you very much to all the panelists. This is from my place, the beautiful Lake Loktak, and thank you all the panelists for the wonderful insight. Yes. Any comments or questions from the floor? I hope everything okay. Thank you very much. Thank you, everyone.
Thank you. I would like to call Dr. N.K. Warrior, who's a medical director and senior consultant in MPR Cancer Center Research Institute, Kozhikode, for his talk on overcoming endocrine resistance in hormone receptor positive in metastatic breast cancer in the era of precision medicine.
Hi there, folks. I think there's been a change in schedule. So if you're looking at your schedule and you see me up here, I apologize about that. Something went on, so they asked me if I'd pop up here and kind of give my talk. So here goes, I guess. I've heard a lot during this day and a half, and this may seem kind of out of tone with the discussions, but I ask y'all to kind of bear with me, and you'll kind of see where I'm going with this, and then hopefully I'll entertain some questions at the end. So basically, I want to talk about some intraoperative imaging modalities. My name is Vijan Devan. I'm from the southern part of the states in Texas. Some disclosures that I have to admit to. 3 of the imaging modalities I'm going to be talking about. 2 we do own at the facility I'm at. 1 is an intraoperative imaging device that I'll show you. I'd looked at it for about 5 years and we finally got it. The second one is another imaging device that I've been looking at for about the last 5 years. I started evaluating it prior to its FDA approval. Finally, it's been approved, and we are getting it into the market right now. I've also agreed to do some post-market data acquisition for them. Thirdly, I've got a tentative agreement with Karl Storz about developing some imaging modalities for them in a specific area of my interest, and I'll kind of talk about that. So basically, why? The biggest thing is I practice in South Texas, which everybody thinks, oh, you're in a first world country, things are smooth, everything's been paid for and all that, and that's really not the case. There's some large cancer disparities where I live at. I see both sides of the spectrum, from availability to fear of care. When I first moved down there, I was used to seeing stage 1 and stage 2, and very rarely a stage 3 and stage 4. However, down where I live, I suddenly started seeing a lot more stage 3 and stage 4, both from esophageal, gastric, colon, as well as breast cancer. If you all had been following the recent developments in the States, there's been a shift in politics that's going to have a huge financial burden specifically for our cancer patients. And things are going to get worse with the ability to provide care. So having all of this put into place, basically I need some modalities to help get my patients a standard of care procedures. This may mimic what people may see in other countries, India, other parts in Asia. Maybe not so much so in some other first world countries, but maybe so. I mean, I'm interested in hearing from Japan and some other European countries. So some basic stats. About 19% of negative margins post-resection on partial mastectomy, breast conserving surgery, whatever you may want to call it, have residual tumor. About 65% of those positive margins reported out by the pathologists actually have no residual tumor. Then 9 to 36% of the general, there's about 9 to 36% of general re-excision rates. Now, this is across the board, not just from surgical oncologists, breast surgeons, but also general surgeons that may be doing breast cases. Some basic data that we all know. About 300,000 breast cases a year in the US. About 40,000 will succumb to the disease. It's the second leading cause of cancer death, obviously the first being lung cancer. But if you want to talk about occurrence of cancer, you toss in some skin cancers there. You can say, oh, skin cancer is a bit more than breast cancer, but breast cancer is way up there too. About 150,000 partial mastectomies are done a year. The usual sequence of events in my hands, again, I'm talking about my hands. The mass is detected by the patient either on palpation or on routine imaging. Then comes the imaging modalities, mammogram, ultrasound, MRI. I've got my personal preference against the result that I get from an MRI. And again, those are my personal preference. I'm more than happy to talk about that. I do like the mammograms and the ultrasounds. Then comes the biopsies. I heard about FNAs, core biopsies. I'm a proponent of core biopsies. I'd like to give my pathologist enough tissue to get me an adequate diagnosis. I'm also a huge fan of neoadjuvant chemotherapy, huge fan. If I can downgrade the tumor and make my oncoplastic surgery a lot easier on the patient, I'd prefer that by far. Obviously, once if it's not able to, then we go straight to surgery, but if we can, we'll do it, then schedule surgery. I'm a huge proponent of partial mastectomy, breast conserving surgery, lumpectomy, whatever you want to call it. It comes in different names. I have a tendency to refer to it in partial mastectomy, and we'll go into that shortly. Then post-resection adjuvant therapy. Now, specifically talking about our breast conserving surgery, our partial mastectomy, or lumpectomies, there are three components intraoperatively that we have to talk about. The specimen going to the pathologist, imaging of the specimen, as well as what do we do with the tumor bed itself. And that goes back to the earlier point where I said about 9 to 36% of re-excision rates. That's patients that have gone out. Later on, the surgeon is told, oh, by the way, we see something at the margin. We see some DCIS that we didn't see at the time of immediate pathology. So, imaging of the specimen. I've got a little video here. If the gentleman in the back can help me load it up. This is the actual device that I use in my own OR right now. It's by Clarix Imaging. It's a company based out of Chicago. They came about, like I said, about 5-7 years ago, and they finally, I finally got it into my OR. I'm hoping that they're gonna pop up the video. Folks? Hello? Sorry about that, folks. I apologize. Can we load that first video that I gave y'all, the Clarix video? The video is not embedded into my talk. It's off the web, so bear with me, folks. It speaks for itself, and so So the basic principle, though, instead of just waiting while they do the basic principle of how do I get to it? I think they're having some issues with getting the video up, but basically, for those of us, the surgeons, basic principle, we all train in using maybe a faxitron, right? That's a 2D image of the specimen. That really doesn't give us a true visualization of all the specimen margins in 3 dimension. Then you have the tomosynthesis unit. The tomosynthesis unit takes multiple pictures in different angles to generate what is a pseudo 3D model. And the example that's often given, if you take a stack of cards, playing cards, and you toss an ace in there, right? Trying to, a simple faxitron image is going to image that whole stack and tell you, okay, yeah, somewhere in there is the ace. A tomosynthesis unit is going to say, yes, within this thick stack, you can kind of see the ace. It may be kind of hidden behind the 10 jacks or whatever. The volumetric imaging allows me to get a 3-dimensional image. It's basically a CT scan of my specimen in my operating room, which then I can spin around and I can visualize where exactly my tumor is and how close it is to my margins. That allows me to get targeted excision at the time of my partial mastectomy. I wish I could show you the video. If you all want to go on the web, look at Clarix Imaging. It's on YouTube, and you can actually look at the video. It's self-explanatory. Having this allows me now to actually, while the specimen is being run off to the pathologist, to look at that and say, you know what, I'm not happy in the superior, medial, inferior margin. It's pretty close. I'm going to go resect, do a shave biopsy at that, and then send that specimen off. Now, the question then is, if it's a solid tumor, invasive cancer, yeah, the pathologist may say, yeah, I see that. Or I may see a little train of cells. But what if it's DCIS? In my institution, they can't really tell me on a specimen whether there's DCIS or not. It's kind of a blind thing. So what do we do then? It'd be nice to be able to image the tissue bed. And that's where this second device comes in. It's from a company called Lumicell, based out of Massachusetts. They came about with this system, again, about 5 to 7 years ago. I started working with them, interacting with them, I should say, prior to them getting FDA approval. It's a ligand that has a quencher that's bound, that it requires a protease reaction to cleave the quencher from the active molecule. I inject it about 2 to 6 hours prior to surgery. It goes to the tumor. I resect the tumor, and at the time of resection, I can image the patient's tumor bed itself. And again, if you want to go to the web, look up Lumicell. There's a video with a collaborator from Harvard that's actually showing a procedure in the operating room, and there's the video on what do you call this, the device itself. Like I said, I wish I could show it to you, but it's not loading up. And so at the time of resection, I can see, hey, you know what? That area is positive. I need to go do a shave biopsy there. So what does this allow me? This allows me to do a couple of things. One, minimize my resection of the tumor, so I have a better oncoplastics outcome. Two, prevent taking the patient back to the OR. And that's huge. I mean, if those of us that have to sit there and look at a patient and say, oh, by the way, on final pathology, they say there's DCIS at the margin. They say, oh, there's a little train of cancer cells heading to the margin. I need to go take it out. Most of us that have done this long enough have that gestalt that says, yeah, you know what? I got the whole thing. There was some desiccation of my specimen as it was walked down to pathology, and that's why the it was about 60-something% of the re-excision positive margins are actually negative, because it's that little fat desiccation that happens between transport. But either way, this is, at the time of surgery, I can actually provide a better resection, minimize the amount of tissue I'm taking, however, get negative margins. And that's the end. At the end of the day, that's the goal of things. What is the next step? Well, I kind of talked about this. And that's my actual, my Lumicell device. It's fairly small. It fits in the corner of my OR. I can image this, the specimen. And like I said, please, I apologize about not having the videos here. It's just technical problems. Where do we go from here? And this is the kind of the interesting thing. And this has been a little pet project of mine for a number of years. Spectral imaging. I come from the area of research prior to my career in medicine, and spectral imaging allows us to see things that our eyes don't perceive. If we think about this simply, the eye can only perceive about 8 bits of information. That's it. What we see is very, very limited. But what's out there is significantly more informative. So those of us that have looked at a CT scan, you can look at different windows. The lung window, the mediastinal window, the bone window, whatever, those are bits of information that are housed within that image that the human eye can't perceive, except when you shift that lookup table to visualize that data set. Spectral imaging allows us to gather that data, present it in a way that we can actually see, and then localize that information within the specimen. Having said that, there's some problems with this. There's nothing that's straightforward. The acquisition of the data set is kind of difficult on a patient. There is trajectories, there is interference, there is artifact. Those are things that have to be overcome, but we're on the way to overcoming that. Spectral imaging allows us to visualize the tissue without administering any drug. And that's another benefit, because like my previous device I was talking about, the Lumicell, it's an expensive drug, I won't lie to you. My pharmacist balked at the first time I brought it up to them, and with the cost of administering the drug. So that is a big issue. But if I have a modality that I can just image the tissue, get the data, and minimize the cost, I think that would benefit everybody. Some of the hurdles, like I said, it's it's the data sets right now. I don't have a true data set that I can say, yes, this spectral pattern is specific for invasive ductal. I don't have that data set, right? And that's where I'm working with the company. Now, just a quick description. For those of you that are familiar with spectral imaging, I do apologize if this seems kind of infantile, but bear with me. Our eyes perceived RGB, red, green, blue. That's it, right? That's our color TV and all that. A multispectral image allows us to look at a bit more information, but they are clumped together. And there is some space between those wavelengths that we are missing some data sets. Hyperspectral imaging is a kind of confluence of all that data, and there is no missing gaps. So that will give you a much finite definition of the tissue base to allow for identification of lesions. Let's leave it as a lesion, not just a basic tumor. So a simple way of thinking about this is you think about a confocal microscope. A confocal microscope gets you an image in 2 dimensions, X and Y, right? But the different wavelengths goes down the lambda platform. So you get a volumetric visualization of your specimen. And that's what we're talking about, trying to get in our patient on the OR table. So I can look at tumor, look at margins, and get some more information. And this is a really, really simple way of thinking about it. You've got the monochrome image, you look at the apple. You've got the RGB image, you can see the nice colors of the apple. A spectral image will give me more information about that apple, whether there's a rotten part of the apple, if there's an overripe part of the apple. And that's what I'm talking about, visualizing my tumor within the tumor-based cavity. And this, since we're at breast meeting, it's about breast tissue, but literally it could cover any tumor base that we are looking at. So, and this is going to be an unbiased request from anybody that's interested. If there's any institution that's interested in participating and acquiring some of the original data sets, I've visited with a couple of people. I'd love to talk to you, because some of the regulatory issues in the States makes it a bit harder for me to gather some data. But I think this is the wave of the future, and I'm kind of excited about where I can take this. So that's kind of my talk. I apologize for not having the videos. Technical ability in this day and age shouldn't have been an issue, but it is. So thank you very much. If there's any questions, I'd entertain any questions. Oh, by the way, my hospital is celebrating its 100th year this year. That's a picture of the, I think it was 75 years ago. In the top left-hand corner, that's a color postcard of it. And then now we've got a 500-something bed hospital that's there. And that's in the top right-hand corner is my clinical team. They made us pose in front of the tomosynthesis unit about a year ago. I have no idea why they put it out there, but anyways, that's my team. Thanks a bunch, I appreciate y'all.
Thank you, sir. For the next session, I would like to invite Chairperson Dr. Daulat Singh Kunwar, who's a consultant in Department of Radiation Oncology from Dehradun.
Good morning, all. So may I invite Dr. Saini sir for conduct this session as a chairperson, sir. May I invite Dr. Lorna Larson, RN, this is President Team Shan from Canada.
Good afternoon. On behalf of Team Shan, I'd like to thank Rakesh and the coordinating committee of the conference for this opportunity. It's my pleasure to speak to you today about some of the work of Team Shan. Team Shan Breast Cancer Awareness for Young Women. We are... Sorry? Okay, back. Yeah. Team Shan is a national charity in Canada. Okay, thank you. Okay. Affectionately known as Team Shan. And we're dedicated to making a difference to young women by informing them about their breast cancer risk and breast health information. And my presentation is going to take you back to Shan's story a little bit, as well as an understanding of some of the background that led us to some of the work that we're doing today around health promotion. So Shan sadly was misdiagnosed repeatedly with her breast cancer symptoms and ended up being diagnosed very late with metastatic breast cancer that had spread from her breast to her bones to her liver. And Shan passed away just a few months afterwards. At the time, the Canadian Cancer Society sent me a quote that if the incidence of a cancer is very low in the general population or demographic group, including young women with breast cancer, they are often misdiagnosed or ignored. And so we realized that Shan's case wasn't just a unique one, that in fact frequently young women were being misdiagnosed. And this is 20 years ago, and sadly the situation is still the same. Some of the more recent work from the Canadian Cancer Society now has some emphasis on healthcare providers as well as young people need to be aware that cancer can affect all ages. Being vigilant can allow a cancer diagnosis to be made early when treatment is most effective. And at the time, we realized that delays can be reduced if AYAs are aware of unusual changes in their skin, breasts, or testes and seek prompt and regular medical care. So we wanted them to understand the issue around breast and for young women to be informed. And the need for AYA target awareness campaigns to reduce the patient interval is still being highlighted and recommended today, and this was from 2023 out of the UK. So Team Shan was in Shan's name, and I was encouraged with my background in health promotion, full career in public health, to use my skills and talents to try to make a difference for young women following in Shan's footsteps. And along with some colleagues and some professionals in the field and some of Shan's friends and others that were just interested, Team Shan was born. And so we wanted to find out what the literature was saying at the time. And the epidemiologists that did our lit review reported that improving early detection of breast cancer can assist in reducing breast cancer deaths in young women. To improve early detection rates, young women must be aware of the signs and symptoms of breast cancer in order to self-detect. And breast cancer can be effectively treated if detected early, and an effective health education campaign can reduce the number of deaths. So this is what we ran with. Using the health promotion framework, we looked at health education and as an activity to look at better quality of life and to actually change behavior so that we could do knowledge transfer and have the young women be self-aware, take self-care, and be empowered to take care of their own health. And so we developed a model, a Team Shan Breast Cancer Awareness Campaign model. It was a multifaceted breast cancer awareness campaign implemented on multiple post-secondary sites across Western Canada between 2010 and 2016. And this was following some work we did around focus testing our materials and resources, piloting on a large university and college campus in Ontario, and as well as speaking to experts in the field, doing an environmental scan. Activities included billboards, public transit, marketing, campus media, campus displays, presentations, resource distribution, website, and social media. Comprehensive, multifaceted. The theme at the time was breast cancer, not just a disease of older women, and we shared Shan's story and her face. So this was our billboard and our poster at the time. And this is one of our transit shelters. And presentations were done on campuses as well through sporting events, women's resource centers, lunch and learns, faculty invites, and as well our resources. And I did put a sample of some of our print materials on the back table at the end, and you can have a look at it and the publication about this project with all the details as well. So the research consultant concluded that the findings support health promotion strategies to reach young women, a population at risk of developing breast cancer. Team Shan was successful in developing an effective health promotion strategy to reach thousands of young women on multiple post-secondary school campuses in Canada. And our impact has been huge. We've heard back from young women, we've heard back from parents, friends, nurses in cancer care centers. And this is one young woman that tells her story, and she helps actually Team Shan with some of her messaging to support us. There's one organization I thank for my life. My early detection was due to Team Shan. So since then, since the end of our sort of 10-year span of developing the model, replicating it, and doing evaluations across the prairies and into Western Canada, we've also learned about the disparities for young women. And we've talked about some of this over the last couple of days, but the rising incidence globally is certainly an issue of public health importance. And of course, the issues around dense breasts, no routine screening, limited knowledge of risks and symptoms, and delayed diagnosis. And these are the issues that Team Shan is able to share. We talk about breast cancer facts, risk factors, some of the things we talked about yesterday around risk reduction, and the symptoms, and self-care around self-detection, healthy lifestyle choices. And of course, young women, as we know, more advanced disease, some more aggressive disease too. And I just highlight inflammatory breast cancer. No one's mentioned that as a concern for young women as well, and they're certainly more prevalent in the younger women. Fewer treatment options, increased distress, and this is another thing that I haven't heard anyone speak about. And that was identified even 20 years ago, the distress caused by late diagnosis. So you have a young person be diagnosed with already a stressful situation, and then there's increased distress because of the late diagnosis. And this has been repeated, and UK actually did a good study on this, and it ends up that there's extra depression, anxiety, as well as the distress. So we also have learned in the last number of years too some of the help-seeking barriers. And one of the key one is lack of awareness, risk, and symptoms knowledge. And this is what our model does, is try to address that particular barrier. And some of the others, too busy, limited access, and whatever, those are things that can be dealt with, that young women can be supported, especially on college and university campuses where you have student health services and whatever, so that they're able to get these other help-seeking barriers dealt with. And being empowered to ask the question, could this be cancer? And there's a number of some samples there about help-seeking behaviors and some of the health promotion activities and initiatives that can help to make a difference. And so just a couple of highlights, and this is out of the UK as well. Women aged 30 to 39 reported uncertainty about what they should be doing with respect to breast health and a lack of confidence in how to perform a breast check appropriately due to limited knowledge about what to look and feel for. They're asking for this information. They need to know, they want to know. Young women do not perceive breast cancer as a relevant and immediate health concern, and this goes back to the fact that there's a lot out there for mammography at age 40 or 50, but there's nothing out there for young women, so they assume they don't have to worry about it till they're 40 or 50. And this is sad because it's putting them behind. This perception has been reinforced by clinical interactions with healthcare professionals who are dismissive about breast health concerns. And so what can health promotion do? Communications strategies can reach the well AYA, similar to our Team Shan marketing and media campaigns, tailored approaches to reach and raise awareness and educate them. And this can be done through the Youth Council for Breast Health that I'm going to talk about, that Rakesh mentioned yesterday, as well as some of the work of Team Shan. And breast health education targeting young women through high school curriculum, displays, presentations, print materials, online messaging, you know, as multi-strategy as you can, because, you know, well, I mean, once they know, they can't not know, but it sometimes takes repetition to actually get through. Now, we have a new theme now, Young Women Get Breast Cancer Too, so this is our billboard. And Shan's face has been important to the young women, and her story resonated with the young women as well. And they needed to know that Shan was a real young woman that got breast cancer and passed away. She wasn't just a young woman that an actor that we just happened to take a picture of and use, that she was actually real. And that's our new transit shelter. And so this takes me, all of that work we've done takes me now to the campus awareness we're doing through the Youth Council for Breast Health. We can use all the public health best practice that we've developed to do this. And this is a wonderful partnership Team Shan has with the Breast Cancer and Young Women Foundation. And I just started and told Rakesh last spring, okay, I'm going to get a couple for you, Rakesh. And then now I have 5 and a couple more in the works, and I think I'll have another 5 by the end of June of this coming year. And it's been wonderful because we've been able to, through their plans, use some of the Team Shan work and have all these activities taking place. And we piloted at one of the larger universities in the spring, and they did some displays at the libraries. They were distributing resources, all very positive. And then as well, they're doing online stuff. They're getting Instagram groups going and presentation displays, resource dissemination. So just a terrific program to reach thousands of young women. And this was one of the displays, that sample. And then I was just at one of the larger universities a couple of weeks ago, meeting 2 of our new co-student leaders and the staff mentor, and reviewing things with them. And this is a sort of sample of the kind of display that we can have on campus. And the other piece that we've done in around health promotion to reach young people was actually develop high school lesson plans around breast and testicular cancer. And we developed 2 lesson plans for grade 9, 10, and grade 11. In partnership with the Regional School Board, we disseminated to phys ed teachers. We updated and reviewed the lesson plans in 2025 with physical health and education teachers, got very positive feedback on that. So I was able to share those resources with teachers across the country at their national conference last spring in Niagara Falls. So these are the kinds of things that we need to be doing, and we need to be making a difference together. It's making a difference together because we have to start with prevention and early detection. We have to do assessment and education and awareness. It's also critical before it's too late. Let's give them all the best start possible. Our online messaging, we're on all the different accounts and support there around breast check reminders, messaging, and just the support and sharing to make a difference. And, you know, Shan's dreams were lost. And she was a figure skating coach. She was a swimming instructor. She was a football coach. And she really wanted the young people she worked with to reach their potential. So her dreams were lost, but we want young women to achieve their dreams through Team Shan and early detection and being able to get on with their lives like Amy. And I just say bravo to these girls. Let's try and do it the same as the Indian Women's Cricket Club.
Thank you. Thank you, Dr. Lorna. Any question from House? Sir, please.
All right, thank you. The next lecture is by Dr. N.K. Warrior. Dr. N.K. Warrior is a medical director and senior consultant at Department of Medical Oncology at MVR Cancer Center and Research Institute, Kozhikode. He is talking to us about overcoming endocrine resistance in HER2-positive metastatic breast cancer in the era of precision medicine. Welcome, Doctor.
Yeah, thank you. Apologies for messing up the slides. The endocrine therapy has become the standard of care, especially the CDK4/6 inhibitor and aromatase inhibitor combination that has replaced chemotherapy and even a single aromatase inhibitor long time back. However, we all know that these patients sooner or later become resistant to this therapy and end up in subsequent lines of treatment will be very difficult. And there are a lot of excitement are happening in this scenario now. So that is the reason why I took up this challenge of talking on overcoming endocrine resistance in hormone receptor positive metastatic breast cancer in the era of precision medicine. The precision medicine has contributed in a very big way now. We can now identify the resistance pathways for endocrine resistance, and the circulating tumor DNA has become more the standard of investigation, so by which we can even identify these group of patients who are going for endocrine resistance even before they become symptomatic or radiologically progressive. So this is the topics. I will skip up some of the slides for avoiding repetition. We know that 70% of breast cancers are endocrine positive tumors. If you look at the survival of metastatic breast cancer, hormone receptor positive, you can see that it is only somewhere around 35%, which is far less compared to the triple positive disease or a HER2 positive disease. We have now several options got approved. These three landmark trials have established the role of combination of CDK4/6 inhibitor and aromatase inhibitor in the first line by showing improvements in metastatic improvement in median PFS compared to the hormones alone. But if you see that the key in the management of advanced metastatic breast cancer is always being the first line response. The subsequent lines of treatment, this response is drastically comes down, and to the tune of 60%. So there is an unmet need to develop treatment to address resistance to endocrine therapies, keeping patients as long as possible, the patients respond to the endocrine therapy in the first line itself. So what are the mechanism of resistance? And if you look at the resistance, you can see that even from the beginning, 10 to 15% of patients in the first line treatment are resistant, and as subsequent the lines goes up, you can see that more than 80% of these patients become resistant to endocrine therapy. So now the guidelines are fairly evolved to define the primary endocrine resistance and secondary endocrine resistance. The primary endocrine resistance is relapse while on the first 2 years of adjuvant endocrine therapy, or progressive disease within first 6 months of first line therapy, endocrine therapy for advanced breast cancer. All other scenarios other than this will be considered as secondary resistance. The hormone receptor positive metastatic breast cancer is a dynamic disease where the especially the ESR1 mutation, which is a dynamic, it comes and goes. If you see the endocrine resistance, there are two mechanisms operates largely. One is the endocrine and the estrogen receptor dependent, and the other one is an estrogen receptor independent. Estrogen receptor dependent is by and large is ESR1 mutation. And the other mechanism is basically PIK3 mutation, AKT, and mTOR pathway activation. So now we have more targets, more the ways of treatment. You can combine or you can target more than one targets at a time, so that you can keep the patient in the more responsive period. And the estrogen receptor gene mutations result in the mechanism of ESR1 mutation is basically they result in constitutive ligand independent activity of the estrogen receptor alpha, and thereby the pathways which are independent of estrogen receptor get activated. And if you see the mutation incidence of mutation going up from 5% to 40% at the end of first year of therapy in case of advanced metastatic breast cancer. So here comes the importance of ESR1 mutation. The reason being whether the ESR1 mutation can be used as a predictive biomarker for detecting endocrine resistance. The answer is yes, because this is proven in the trials by showing that ESR1 mutation is associated with worse outcome, especially the overall survival. So the subsequent lines, whether this can be a better biomarkers, definitely this study, Emerald study, have utilized the concept of circulating DNA and thereby detecting ESR1 mutation, and found that the patients on the elacestrant, which is used in the second line, had a 30% lower risk of disease progression compared to those in the standard of care arm. And similarly, the other trials have also shown improvements based on the ESR1 mutation directed therapy. If you see the prevalence of ESR1 mutation, and you can see that in the subsequent line, always the pickup is better with the liquid biopsy rather than the tissue, probably due to the heterogeneity developing on treatment. So ESR1 can be better picked up in the liquid biopsy or circulating tumor DNA. And this has been proved in one of the study, the classical PADA-1 study, which has utilized this circulating DNA for detecting ESR1 mutation. And with this background, this trial has done, and this is something which is very interesting. And today morning, Dr. Shyam was talking about this trial only. Here, the advanced metastatic breast cancer hormone receptor positive patients are put on aromatase inhibitor plus CDK4/6 inhibitor. After 6 months, they are screened for ESR1 mutation by looking at the circulating tumor DNA. If they are found to be ESR1 mutation detected, and if a patient has no symptoms or patient has not progressed radiologically, probably these patients are randomized to two groups. One group were given camizestrant, which will replace aromatase inhibitor. The second group continues to receive the standard of care arm. And as like any other metastatic disease, at very frequent intervals, these patients were evaluated for circulating tumor DNA as well as radiological investigation once in 2 or 3 months. And it is something which is amazing to note that 42% of these patients develop ESR1 mutation over a period of this trial. And the SERENA-6 is a very balanced baseline characteristics are all balanced. All the parameters like the time of ESR1 mutation detection as well as time from the introduction of the camizestrant and randomization, CDK4/6 inhibition, continued at randomization, all are matched the baseline. And switching to switching aromatase inhibitor to camizestrant with the continuation of CDK4/6 inhibitor guided by emergence of ESR1 mutation during the first line therapy ahead of actual disease progression significantly improved PFS in patients with hormone receptor HER2 negative advanced breast cancer. And this benefit is consistent across CDK4/6 inhibitor and in the second progression-free survival as well. Not much toxicity when you combine camizestrant, only the neutropenia becomes grade 3, and we all know how to manage the grade 3 neutropenia very well. So can we target, can we consider other resistant pathways also other than the ESR1 mutation, because there are other pathways also gaining importance in the endocrine resistance. If you look at the genomic alterations, you can see that 50% of patients have, in addition to ESR, they have other mutations like the PIK3CA mutation, PTEN, AKT1, and so on. And the importance of these mutations are, they are not dynamic, they are constant. So something which we can look upon so that we can target them and control them with the targeting agents. So in this scenario, we already have alpelisib plus fulvestrant as the second line treatment for inhibition of PIK3 mutation, and now everolimus and exemestane to target mTOR pathway. And now to this, we are now adding inavolisib plus palbociclib, and along with fulvestrant, and that too in the first line management. And capivasertib is another molecule which inhibits the AKT pathway. So this area is now very interesting, and there are a lot of molecules coming to overcome this endocrine resistance, knowing very well that we can detect these pathways, picked up these pathways very well with the improvements in the molecular oncology. So I want to tell you that inavolisib used for the PIK3CA mutated population, and with a proven improvement in PFS. The capivasertib is another potent selective inhibitor of AKT, and which is studied in CAPItello study, and where the capivasertib along with the fulvestrant used for AKT pathway altered tumors, and found that the dual and the capivasertib plus fulvestrant significantly improved median PFS in the overall, and as well as the PIK3CA and the other co-mutation group as well. And these drugs are very promising, and adverse events are not very intolerable. Diarrhea is the common side effects for the capivasertib. And in conclusion, the algorithm is changing, and it was keep changing till now, and fairly constant, and hope that with the more and more agents identifying the role in the algorithm, it might get stabilized in the future. So the first line options, treatment options for these patients, the standard of care is always aromatase inhibitor or fulvestrant plus CDK4/6 inhibitor combination. And once this patient, or now we can probably have one more options like inavolisib plus palbociclib for high risk PIK3CA mutation as the first line option. And if once the progress further, probably there are other combinations like fulvestrant plus capivasertib, or fulvestrant plus alpelisib and elacestrant if it is ESR1 mutation positive, along with if they are found to be positive for BRCA, then PARP inhibitor also become one of the second line option. The patients not a candidate for further endocrine therapy, then probably you have to think about other options like detecting low HER2 or ultra low HER2, where you can offer them TDXD and so on. And if they are BRCA positive, always consider PARP inhibitor. So this is something, the mutation, the analysis. The prevalence of ESR1 mutation in HR positive advanced breast cancer after adjuvant AI, it is 5%, but at the end of first line treatment, please remember that it is up to 40%. and mutation dynamics is emerged following prolonged endocrine therapy, and the patient prognosis, negative prognostic factor if you find out ESR1 mutation. And other co-mutant, there are 3 or 4 co-mutant. They are also gaining importance, and some of them are up to the tune of 40% prevalence in this group. All the guidelines have now recommended the biomarker testing. If you see the ESMO, ASCO, and NCCN, the ESR1 mutation has become the standard molecular recommendation, except for the ABC, and that too from the liquid biopsy, that is the circulating tumor DNA, as recommended by NCCN and ASCO, but ESMO has not included liquid biopsy as the preferred option. So in summary, take-home message is the hormone receptor positive, the first-line treatment setting is well established with the CDK4/6 inhibitor AT combination, probably the maintaining the patient in the first-line treatment is the key, and identifying the mutations or the resistant pathways early in the course of the disease by frequent checking is possible now, and that should be the way forward. And conducted biomarker testing at the earliest opportunity informs treatment decision to optimize patient outcomes. Thank you so much for your patient listening. Thanks.
Thank you, Dr. Verghese. Is there any question for him or comments? No? Thank you. Thank you so much. Is the panel discussion now?
Till the panel discussion comes up, we will play a small video of Mahima Chaudhary, who will be joining us in the next about 20 minutes after the panel discussion. Can we play the video, please?
Breast cancer, and you are very lucky. मेरे डॉक्टर ने मुझे ये कहा, मुझे बहुत गुस्सा आया कि लकी और कैंसर आप एक साथ कैसे यूज कर सकते हो, लेकिन मेरी एक आदत ने मुझे लकी बनाया, मेरी रेगुलर हेल्थ चेकअप वाली आदत। कितना अच्छा होगा कि इस आदत की शुरुआत आप अपने घर से ही कर पाएं। कैंसर होना ना होना ये हमारे हाथ में नहीं है, पर उसको जल्दी डिटेक्ट करना, जल्दी पकड़ना हमारे हाथ में है। मैं महिमा चौधरी, एक एक्टर, मदर और कैंसर सर्वाइवर।
Well, now we have very important panel discussion on doctor-patient survivor roundtable forum. It's about psychosocial, lifestyle and survivorship challenges in young women with breast cancer. And moderator for this session is Dr. Preeti Jain. Dr. Preeti Jain is Director and Senior Consultant at Department of Surgical Oncology, Sapt Rishi Hospital and Cancer Center, Jabalpur.
Thank you so much. Good afternoon, everyone. At the outset, I would like to congratulate and thank Dr. Vaid sir for having us here and organizing such a wonderful scientific feast. And I congratulate and thank him once again for thinking about this kind of a session where we can discuss the patient, the survivors, the doctors and the caregivers. They can sit together and talk. So can I now have my panelists here? I welcome Dr. Lorna Larson, Dr. Mary, Dr. Indra Jasuja, Ms. Yashika Bharadwaj, Dr. Shraddha Salil Chaudhary, Dr. Shrikala Nair. I welcome all of you. You've heard Lorna and Dr. Mary earlier. Dr. Indra Jasuja is the Honorary Joint Secretary of Indian Cancer Society Delhi branch. Dr. Shrikala Nair is a clinical psychologist. Dr. Shraddha is a consultant in gynae oncology, and Yashika is a warrior. All right. So I am a surgical oncologist, and the moment I see a patient, a file opens in my mind, and my mind starts telling me the treatment agendas. You know, whether this patient is fit for a BCT, whether I should do an MRM for her, what is her ERPR, HER2 status, will she require an NACT or not. Similarly, the patient's spouse, the relatives, they have another agenda, like where will I arrange finances from, who will support her when she's inside the hospital, where should I get her treated. So everyone around is having a different agenda. But let's start with the patient herself as to what actually goes on in her mind the moment she hears the word cancer at a very young age, when she's ambitious, she's dreaming of a wonderful career ahead, she's dreaming for a good life partner, or already has one and looking forward to having a family. So I'll ask Yashika. Yashika, what went on in your mind when you heard about your diagnosis?
So thank you for having me here, first of all. Cancer is just a 6-letter word, but I think lack of awareness is what makes it more scary. When I was first told I was diagnosed in April 2024, I was diagnosed with TNBC stage 4 directly. I think it's lack of awareness that scared me, and the first thought that crossed my mind was, am I gonna die this soon? Because I was not aware that there are so many advanced treatments nowadays that can actually help me making my life better, making the lifestyle that I'm currently living improvised. But that is the assumption that was there in my mind, that am I gonna die this soon? And you're right, when you think about, there are a lot of dreams in my mind. I need to do a lot of things. I'm very young, so what is gonna happen?
Yeah, true.
But I think that's where, and the problem with our generation is that we keep on Googling everything. So that is what even I did, unfortunately.
It's kind of shocking for anyone to hear about the diagnosis. But did you doubt your diagnosis? Didn't you feel like changing doctors or going to someone else, getting a repeat biopsy done?
I did.
I conducted a survey before coming here. I just called up a couple of my patients and tried to figure out as to what was their initial reaction. So most of them said that we didn't believe what you said.
I mean, it was shocking because it just came up all of a sudden. I had no symptoms. I was living a perfect life, and it just came all of a sudden. I felt a lump, and I got it checked, and that's where I got to know that I have cancer.
Yeah.
But obviously,
so
I think
you had acceptance pretty
I think
early.
doctor plays a very important role when it comes to my cancer journey. Your doctor is your greatest companion in this journey. And I think I also took second opinion, 2-3 opinions, that's what is required. So I did that. And that's why, my companion with me in this journey is Dr. Ved. He's the kind of doctor, when I met him, he sort of given me a confidence that, okay, you're going to go feel, better soon. You're going to be fine. And that is, all that created a difference for me.
Doctor's support is very, very important. Dr. Mary. Dr. Mary is a surgical oncologist and a survivor and a winner herself. You suffered, did you suffer breast cancer only, right?
Yes, now I'm not that young anymore.
Yeah,
but back then, yes, I was.
But Dr. Mary, did you feel, why me?
Yes, and even back then I was a surgeon, a very young surgeon, just out of my training, but I denied what was going on. I should have known better, actually, because I even had been told in medical school about it, but I even denied, because it doesn't happen in young women. Yes, it does. I was lucky that but maybe I can tell that later, because you have a lot
That's
to...
great, yeah. So at diagnosis, you have a fear of death, you have a fear of disfigurement, and did you all worry about how your relationships will be in future if I get treated for cancer, if I have cancer? Did it cross your mind that the relationship status will change, or the equation in the family will change? No. All right.
No. I think I'm lucky to have the best parents, so I didn't have that fear at all.
That's amazing. So Dr. Mary, as a surgical oncologist, when you see a young patient with a breast cancer, how is your decision making different from the ones at a little older age as compared to the younger ones?
Yeah, actually, it's not just the surgical treatment, but the treatment, the whole multidisciplinary treatment. And yes, of course, the woman is very young. You have to do absolutely everything to treat her the best way.
Yes.
But on the other hand, you also shouldn't over-treat her, because that's also not necessary. And it's that balance that you're looking for. And especially in young women, there's so much going on around, the kids, the job, the fear of the future. And we as surgeons are basically a little more technical oriented, so I definitely need other people around, like very good trained nurses and other people to really take care of all those aspects as well.
Yeah. And coming to you, Lorna, you have served cancer patients for a long time. I heard that you were working as a nurse, right?
Public health promotion
Public health.
specialist, yes.
Okay,
But
okay.
I was a mom.
But you would have interacted with a lot of patients who are under treatment right now and then post-treatment also. So
no,
what do you...
I work with really the well young women.
Okay.
On
for
college and
awareness.
university campuses. and
More
in
towards
community.
awareness.
Yeah, but I
All
can
right.
share as a mother because I
Yeah.
lost my daughter to breast cancer.
Yeah, that will be great.
Yes.
That perspective.
And so as a mother, it was, why Shan? Why not me? I had a life, I had my family, I had a career. Shan had just graduated from university, just starting to head off on her life. It was tragic. And same for her friends. Why Shan? She was a model of lifestyle. There was no family history. It was just random and sporadic, which we say about a lot of, cancer in young people.
Yeah, it's extremely painful to see a very close one, someone who's very close to your heart, your own child suffering from this kind of a dreaded disease. It's pretty painful.
Yeah.
So, yeah, so moving on to the treatment part of it. Chemotherapy is something which patients dread a lot, if I'm correct. Because this is what I have gathered from my patients. They were more worried about the side effects of chemotherapy rather than anything else. Dr. Mary, would you like to comment on that? What are the concerns that patient generally has about undergoing chemotherapy?
Hair loss is sort of what comes up first in patients, because that's of course, something, and then the other, and
they
then
always ask about, can you do anything that I don't have a hair loss? So are there any devices, any treatments, anything available? Because they sometimes Google and come to me about some scalp cooling devices and stuff. Are they effective? Do they exist in the first place? Are they effective?
They
And
do
how
exist.
effective
They
are they?
absolutely exist. They are a little bit effective, but to a high cost as well. It's pretty nasty to have it on your head. It's quite painful. So it's and it doesn't make you keep your hair. It's
Okay.
a
It
little
helps you
less
grow them
hair
back?
loss.
Okay.
Yeah. Yeah.
Okay. It stimulates the growth of hair,
Yeah.
is it? All right. Okay. Coming to you, madam, the gynecologist, I'm sorry. Their issues, their concerns about their sexuality and fertility.
Yes.
Their concern about sexuality and fertility.
Right. So as a gynecologist, and here we are discussing about young women breast cancer survivors, and some of these people, patients are on drugs which cause estrogen suppression.
Yes.
And they are in premature menopause. Menopausal symptoms can be divided into 3 categories, and patients may face psychomotor or mood disorder. They may face vasomotor symptoms, which would be the most common symptom is hot flushes, or they may also face urogenital symptoms, typically vaginal dryness, which affects the sexual function. We should actually individualize the approach and talk to these girls and to understand what is the exact menopausal symptom which is bothering them.
Right.
And as we all know, in hormone positive cancers and even in triple negative breast cancers, we cannot offer the patient traditional estrogen replacement therapy.
Right.
But alternative therapies, especially keeping in mind the particular problem which this woman is going through. If it's a mood disorder, we can help her with such drugs. If it's vasomotor symptoms, we can help her with drugs which will improve the hot flushes.
Right.
And in urogenital symptoms, we try to use drugs which are not medicated, try with hyaluronic acid and things like that. And only in very extreme cases, in trial situations.
So you try to give
hormones
them
can be-
a little non-hormonal kind of
the
symptom-directed treatment for those.
symptom-directed and
And how many patients actually who are nulliparous and are suffering from breast cancer come to you for a counseling regarding preserving their fertility or, preservation of their ova and or in embryo preservation?
So I think this is a need of the hour where we all talk about an approach where it's a team approach. The medical oncologist, the surgical oncologist, the reproductive specialist and the counselor actually need to be there for this woman as a team. My esteemed panelist did share that she looks at her medical oncologist as a source of inspiration, and every word he speaks is more important than probably the air she breathes.
Absolutely,
So it's a team approach, and fertility preservation is a very important aspect of womanhood.
Yeah.
Whether she uses these gametes or not is a separate issue. Whether she opts for fertility preservation or not is also a different issue, but the counseling of the fertility preservation must be offered to every cancer patient irrespective of age, parity,
Yes, that's
and
very
status.
important. If it comes from their doctor himself or herself, the patient will be little more motivated. Otherwise, lot of them I have seen, they are only worried about their preserving their life. Doctor, let me be alive first. Or even the family members are like, let her be alive first, then we will think about the family. So if the doctor counsels or the treating physician counsels them regarding the fertility preservation, they might be
Actually, I
better
think it's a
off.
very important part of womanhood. So when the woman knows that we are talking about fertility preservation for her, it helps her overall deal with her cancer in a better way.
Right. Shri Kala madam, can I ask you, do you see patients coming to you suffering from breast cancer, undergoing treatment for a kind of psychological counseling, or are psychologists now part of the treating team in cases of breast cancer?
Good morning, everyone. Yes, they do, and at Medanta, we are I'm also part of the initial consultation. When the patient gets the chemo for the first time, I'm also supposed to meet the patient and then ask her about her, concerns about the treatment and ongoing whatever thoughts.
So what are their top 3 concerns that they discuss with you? Is it their life, their family, their body image? What are the top 3 concerns?
I think there are, it comes as a catastrophe or a disaster, and it follows with grief. So that grief has to be taken care of in different stages, denial and then argument, acceptance. Acceptance comes later, but then in between.
So
they
what
bargain
treatment or
also.
what kind of therapy you give to them for them to feel at
CBT,
ease?
mindful CBT is what I normally suggest. That also part by part, because I start giving all the information. If I start giving all the information in one bit, I don't think they'll be able to accept it in the long run. So it's always better to cut it into different chapters and then take the first part. It's most of the time now with young patients, I feel. Not why me, it's what next,
Right.
And we really have to sit with the patient and give that confidence to the patient. That,
And how long does your patient require counselings or some kind of therapy or treatment?
At least 3 to 4 sessions, and I still have patients who are already
At the beginning of their treatment?
Absolutely. And
So it's very important to understand that the initiation of treatment and when the diagnosis is disclosed to her, that's the time of maximum distress for the patient. Right. So moving on to, I think we will move a little more quickly. Survivorship. Madam Indira ma'am, Indira Jasuja ma'am.
See, that's a very important part of, I would say, the treatment, because it's a long drawn thing. Once a person comes out of cancer, even then the fear of getting the disease again and again is very much there. How the person is going to adjust to the environment Because you see, cancer impacts you in such a way that your personality changes. Your
Yes.
interpersonal relationships, they are also warped. So what we try to do, especially when we are counseling or whenever we are giving emotional support, is trying to make the person come back to his normal self,
Right.
which is a very important part so that he can deal with the rest of his life.
Right.
The rest of his life has to be very, very happy, and whatever he has to be contented with.
Yes,
that.
and
That
they
is
have
a
to be
very-
productive also, isn't it?
Be productive.
They need to
because
get their job back.
you
They
see
need to
what
be
is-
back to
now
work.
how our NGO is made.
Yes.
I will tell you a little bit about it. We are made up of survivors. So it gives us such enrichment when we go and talk to the patients or we are, with them. When we stand in front of them, it's a motivation for them to get perfectly well. So that survivorship, you are gaining something yourself and the other person is gaining something from you. That is something very, very important.
Yeah,
It
so-
brings happiness to you, it brings happiness to others.
Yeah. And just one last question to Lorna. How does the community support, or how can the community support these patients get out of their issues about their cancer and their treatment issues?
Again, I think it's the opportunity for community to listen, really, and to have opportunities to be able to talk about it and work through some of it. And I wanted just to go back to Shan, and when she was finally told that she had cancer, in some ways it was a relief. And she actually looked towards the tests and the treatment with determined optimism and, let's get this show on the road. Because she'd been dismissed for so long and just not having her symptoms dealt with. So all of those things are taking place. But yeah, community has a role to play. They do. But for young people, it's tricky because if they're still in high school or how the friends respond to them.
Yes.
And how they may be there or not be there.
Right.
And it's a whole shifting. And so they need to understand, and sometimes I guess it's the parents' role as well to try to help her friends and whatever to navigate through
Yeah,
it.
so family support and support of their peers, and of course then probably some support
And
groups can help.
siblings. And siblings.
And siblings, of course.
Just one sentence here.
Yes, ma'am.
Caregivers are very important to us because it is the caregivers who try to bring back the person into the
Right.
fold.
Right.
That's very.
Yeah.
Thank you very much. Thanks to all my panelists. Thanks to all the audience for your patient listening. Thank you very much.
Good afternoon, ladies and gentlemen. At the very outset, I thank everyone for taking time out on a Sunday morning, and now it's extending into Sunday afternoon for this very critical and a very important, pertinent cause of breast cancer in young women. And as I said yesterday, that a lot of data is extrapolated from older women to the treatment of younger women. So this is a special population, a more vulnerable population, and we have heard over the last 2 days the vulnerabilities around it, the age, family, everything stops at the stroke of the diagnosis. And there are so many issues around that diagnosis, around that treatment, post-treatment, getting back to life, family, job, so many things, fertility, children. We have had great deliberations over the last 2 days, a lot of learning, a lot of exchange of ideas, and I must thank Dr. Rakesh Kumar, Professor Rakesh Kumar once again, for this very special opportunity given to us to host this conference, bring people around the table on this dais to express their opinions, for the cross talk and the exchange of the ideas, and great scientific presentations. We heard from the original researchers yesterday, this morning, where science is as on date and where we are headed. I'm grateful to everyone who came, all the faculty, our sponsors who have made this event possible, all the students, all the young oncologists, all the young learners, and I'm glad we could fire up those minds. We have had beautiful posters, and the results are yet to be announced. Some of them were really, really at that level. Professor Rakesh, once again, thank you in person to you for catalyzing this event, for bringing this idea to fruition. And we do hope that the Breast Cancer in Young Women Foundation chapter in India becomes more robust and moves on year with a broader base, more inclusive, and more scientific and socio-cultural discussions and discussions around the patient, to bring it to a more patient-centric standpoint. I think we are just awaiting the guests to arrive. Till then, we'll have another message, a video played in the meantime. Could we have the video? Thank you so much.
Mahima, you have breast cancer and you are very lucky. मेरे डॉक्टर ने मुझे ये कहा, मुझे बहुत गुस्सा आया कि लकी और कैंसर आप एक साथ कैसे यूज कर सकते हो, लेकिन मेरी एक आदत ने मुझे लकी बनाया, मेरी रेगुलर हेल्थ चेकअप वाली आदत। कितना अच्छा होगा कि इस आदत की शुरुआत आप अपने घर से ही कर पाएं। कैंसर होना ना होना ये हमारे हाथ में नहीं है, पर उसको जल्दी डिटेक्ट करना, जल्दी पकड़ना हमारे हाथ में है। मैं महिमा चौधरी, एक एक्टर, मदर और कैंसर सर्वाइवर।
I think the key message out here is early detection. There is no doubt about that. Early diagnosis means the smallest amount of tumor, less surgery, less treatment, and the best outcome. That's the key message, what she's given in this video. And we would hear from her own life journey and the inspirational words she has for all of us. Going back to the deliberations of the last 2 days, one of the critical points which we discussed, we had senior faculty from India who also alluded to the point that the best way forward would be collaboration, data collation, sharing of information, sharing of knowledge, and more publications. And that can only happen if we professionals come together more often on these occasions and commit ourselves to achieving this goal towards better understanding of the disease and defining better treatments and serving our patients better in the coming years and days. I'm very grateful to all the NGOs who are present here and all the patients, the caregivers, their families who have taken time out. They are our inspiration. And that's what keeps the doctor also going. Treatment obviously has facets to it. And in the young women, the point which has been brought out again and again since yesterday has been the vulnerability, as I alluded to. We have a couple of minutes. If somebody wants to offer a comment or any personal opinion, we'll be very happy to hear that. We can pass the mic around, or you could come to one of the mics nearest you. And Professor Rakesh, I think it will be most appropriate to hear you as the pioneer, as the researcher who's worked at MD Anderson, who's worked at Memorial Sloan Kettering, who's mentored people around, and he's worked with about a dozen Nobel laureates, and that was the reason why we heard one of the Nobel laureates yesterday on this program.
Let me just start by thanking Dr. Ashok Vaidya for agreeing to take up this lead and champion the cause of young women breast cancer in India. Well, what I all did is to put together the best of the best, bring best of the science, and be part of this commitment in India. Having come from India, this was one of my contribution in the next coming years for the country. And I'm ready to partner with each one of you. You could reach us through Dr. Ashok, you can reach me directly, but if you have any passion to do something important for your nation, for your country, for your patients, and for your colleagues, just reach out to me. I will give you a roadmap what to do. Most of the roadmap I will share are close-ended, means you could see the end before you start. So this will not be loss of your time, it will be the best use of your time. I'm here to fully commit, bring the science, bring the professionals, and continue the journey together.
So, any voices from the audience, please come to the nearest mic, or you could pass on the mic around. And
can I ask a big question? I'm a journalist. Can I speak? Yes.
please.
Sir, I am a health journalist of nearly 30 years in Delhi. Once Dr. G.K. Rath told me 10 years ago that we shall defeat cancer in next 15 years. My question is, are we anywhere near defeating cancer?
Dr. Chitalkar is here. Sir, I have the honor of inviting you to offer a comment on that, because none other than you here in the audience who's more experienced.
Thank you, Ashok. I think it's a wonderful opportunity that we had last 1.5 days, courtesy you and Dr. Rakesh, to answer your question. To answer your question, well, there's a huge progress in childhood cancer the last 50 years, from almost no survivors to 90% survivors. In adult cancer, anybody getting diagnosed with a cancer above the age of 40 in the year 2000 had a 2/3 chance of surviving more than 5 years, and now it is much more than that. Anybody getting cancer in the younger age, that is 15 to 30, not a child, not an older adult. That is the focus of this conference, and that is also the focus of the foundation which I represent, Teenage and Young Adult Cancer Foundation, किशोर और युवा कैंसर न्यास। ये भी सक्रिय है भारत में पिछले 10 साल में, और इनका उद्देश्य है कि जो युवा व्यक्ति हैं और किशोर व्यक्ति हैं, उनमें भी कैंसर के जो लक्षण होते हैं वो जल्दी पकड़े जाएं, उनके आयुर्मान बढ़े। it was dismal. It was 30% in 1999. Now it is about 60%. It's improving. And I think the deliberations are showing that today gradually, हम लोग कहते हैं, डॉक्टर लोग कहते हैं कि कोई भी बीमारी को क्रॉनिक बीमारी बना देते हैं. आप जानते हो ब्लड प्रेशर एक क्रॉनिक बीमारी है, डायबिटीज एक क्रॉनिक बीमारी है, उसकी दवाई लेते रहो आप ठीक रहोगे. तो धीरे 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 हम लोग वहाँ पहुँच रहे. डॉक्टर जी.के. रथ ने जो बोला है, व्हाट यू मेंशन, वी आर रीचिंग gradually at a time. It may not happen. He said 10 years back, 15 years ahead. So it means it should happen next 5 years. No, I think it will take a little longer, maybe 10 years more. But we are going to gradually convert. हम लोग डॉक्टर वैद और हम, we are cancer specialists. हम लोग कितने प्रकार के कैंसर ट्रीट करते हैं? शायद 200 प्रकार के कैंसर ट्रीट करते होंगे, बहुत सारे. सो हर एक कैंसर की स्टोरी अलग होती है. बहुत सारे कैंसर हम लोग जीत चुके हैं लड़ाई, और कुछ कैंसर्स रास्ते में हैं. धीरे 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 वी आर इम्प्रूविंग द रिजल्ट्स विद द बेस्ट एविडेंस, बेस्ट अवेयरनेस, बेस्ट एक्सेस. एविडेंस हम लोग डेटा प्रेजेंट करते हैं, जो भी रिसर्च हुआ वी शेयर इट. अवेयरनेस, वेल दिस द होल हॉल इज फुल बिकॉज ऑफ अवेयरनेस. एंड एक्सेस मीन्स वंस डायग्नोज्ड यू शुड रीच द कैंसर सेंटर एज सून एज पॉसिबल. उसके बाद एक और चीज होती है, एक युवा व्यक्ति चाहता है कि उससे युवा व्यक्ति जैसा ट्रीट किया जाए, न कि 70 साल जैसे व्यक्ति है. यू शुड नॉट बी ट्रीटेड लाइक अ ओल्ड पर्सन, यू शुड नॉट बी ट्रीटेड लाइक अ वेरी यंग चाइल्ड. सो एज अप्रोप्रिएट केयर. सो अवेयरनेस, एक्सेस, एज अप्रोप्रिएट केयर, एंड लास्टली इज एडवोकेसी. आपने कैंसर ठीक हो गया आपका, जब आप जाते हो तो द स्कूल में या कॉलेज में मना किया जाता है, भाई साहब आप ना अपने बेटे को कॉलेज मत भेजिए, दूसरे बच्चों के ऊपर असर हो जाएगा. बिल्कुल मिथ्या है. Quite to the contrary, you should actually go and motivate others. Others should help. So we should have advocacy in educators, advocacy for employment. नौकरी मना की जाती है कभी कभी. He is suitable but he is told आपकी medical history में cancer है, so we don't want to take you. And so on. So, and of course with the government, so all the agencies. So awareness, access, age appropriate care, and advocacy. I think if you do that, I'm sure in the next 10 years or 15 years, we'll make cancer a chronic disease. And that is equal to conquering it. Thank you. हाँ जी, हाँ. हाँ, हाँ.
ये chronic disease है तो हार्ट का रोग मैनेज करना ज़्यादा आसान है या कैंसर का रोग मैनेज करना ज़्यादा?
वो दोनों अलग अलग विषय हैं.
नहीं, किसी डॉक्टर ने हमको बोला था, कैंसर के जो डॉक्टर थे, कि अब तो धनंजय जी अब कैंसर को मैनेज करना हार्ट के रोग से मैनेज करना ज़्यादा आसान है. तो हमने सोचा आपसे पूछ लें कि हिंदी में
जिस प्रकार का कैंसर है उसके ऊपर आ गए.
Dr. Chitalkar, I have the honor and privilege of presenting to you Mahima Chaudhary, who is not only a screen icon, but a dedicated advocate, voice for the survivors, not only an award-winning star, but a champion of human spirit. Ladies and gentlemen, very warm welcome to Mahima Chaudhary, and I invite Tejaswini to do the honors of the formal introduction of our star guest.
So I've been given the task of introducing T. Mahima Chaudhary, a task quite unnecessary, I believe. She's world-renowned. She's one of the most beloved actresses of the Indian movie industry. She has given us absolutely iconic roles and performances that we remember till date. And her work actually goes beyond just the silver screen. Can we move to the slides? She also campaigns for the Trinamool Congress, and she's also a doctor. She holds a doctorate degree given to her from the ACS Media. She is a huge animal lover. She has a pet that she adores called Antonio, and she's also campaigned for PETA. So ladies and gentlemen, please can we have a round of applause for Mahima Chaudhary? And ma'am, could you please share your journey today with us? Thank you so much, Mrs. Kumar.
Thank you, Tejaswini, for that wonderful introduction. And I think let's get going. The theme is Zara tasveer se nikal ke tu samne aa. And none other than Mahima Chaudhary could do justice to it. As I said, she is not only a screen icon, but a hero in real life. आपने एक बात उसमें बोली, लकी कैसे हो सकता है और अर्ली डिटेक्शन, जल्दी पकड़ने से क्या मैंने और आपने क्या महसूस किया और क्या मैसेज आप जितने लोग यहाँ पे हैं उनको देना चाहेंगे, and thousands of our viewers who are at the moment on various social media.
Dr. Saab, thank you so much. Dr. Saab is award winning, so I am very, very nervous speaking with him. But जैसा आपने सवाल किया कि बिल्कुल कैंसर नाम सुन के तो सब घबरा जाते हैं, but जिस चीज़ को आज आप यहाँ प्रोमिनेंस देना चाहते हैं कि जितना जल्दी आप डिटेक्ट करें उतना आपका ट्रीटमेंट छोटा होता है और ज़्यादा चांसेस ऑफ सर्वाइवल होता है. ये मुझे इतना पता नहीं था, बट जब मुझे डिटेक्ट हुआ तो डॉक्टर साहब ने कहा कि यू आर वेरी लकी, इतनी जल्दी हमने पकड़ लिया, इसको ट्रीट करने में हमें बहुत आसानी होगी. तो यही मैसेज शायद डॉक्टर साहब आप और मैं देना चाहते हैं आज सबको कि स्टे एट द टॉप ऑफ योर हेल्थ गेम and get your regular checkups, because it will really save you a lot of trouble if there is going to be any trouble in the future. जैसा मेरे साथ हुआ, डॉक्टर ने कहा you're lucky, हमने बहुत जल्दी पकड़ लिया. So I think that is a very, very important thing, especially in cancer.
Wonderful. I think early detection means small amount of disease, less surgery, less treatment, better outcome.
Yes.
बहुत बढ़िया. अब देखिए जब diagnosis, you're given it's like a bolt from the blue, and suddenly your life stops. What happened? You did a mammogram. A mammography said there is something. And how the subsequent months, and I'm sure the years, it just doesn't go away. But how was it? And what brings that courage and that belief to come back to life?
I think it's doctors like you who give us the confidence. जैसे आज सुबह भी जब मैंने आपसे चर्चा की, आपने कहा बहुत सारी medicines हैं cancer cure के लिए आज. There's a lot of medicines. And यही मेरे doctors ने भी मुझे कहा था. And मेरा जो diagnosis हुआ वो बहुत slowly हुआ. As in जो मैं regular checkup कराती थी वैसे ही regular checkup के लिए मैं गई. और जो सोनोग्राफी कर रही थी और मेमोग्राम का जो रिजल्ट देखा उन्होंने कहा आई सी कैल्सिफिकेशन, तो go and show it to an oncologist. We all know oncologist is somebody who deals with cancer. So that was my first hit. I said, really? जब मैं oncologist के पास गई, they did a physical examination and they said, नहीं, I don't suspect cancer at all. But हम biopsy करेंगे. Biopsy negative आई because मेरा जो tumor था वो बहुत छोटा था. And he said, anyway, since this is DCIS, so we will remove the pre-cancer cells. जो मेरे cells थे वो pre-cancer cells suspected थे. But जब surgery हुई उस time पे वो लोग cold biopsy भी करते हैं, उसमें उनको 1 centimeter, 1.5 centimeter का already cancer cells मेरे body में से मिले. तो उन्होंने फिर मुझे port लगा दिया. And when I came through the surgery, that's when I heard the doctor say, Mahima, don't get alarmed. हमने एक port लगाया है chemo के लिए. You're very lucky. It was a very small tumor. We found cancer cells. So it was a mixed.
तो आपने डॉक्टर को ये पूछा कि बायोप्सी की क्या ज़रूरत है? What's the need for a biopsy? A lot of people have a myth. One of the myths in the society is you touch it,
and it grows.
spreads,
Yeah.
it grows. So what was your reaction to a biopsy?
That I should get it done.
Excellent. So everybody should get it done.
Yeah, so when he said do a biopsy, I was like, yeah, sure, let's rule it out. But, you know, जो आप सुनते हैं, particularly because, you know, our society is very celebrity driven. And मैंने Hollywood actress Angelina Jolie के बारे में सुना था. She had a particular BRCA cell sort of in her genetics. And क्योंकि उनकी मासी और उनकी mother had succumbed to this BRCA kind of cancer, she was very sure that once she was done with having children, she would remove her reproductive organs. And she removed both her breasts, her uterus, her ovaries. And I had that knowledge. So when the doctor said, कि आपको pre-cancer cells हैं, my immediate reaction, because of that knowledge, I said, doctor, I'm okay, you can remove both my breasts. He says, no, it's not so drastic. But this is the kind of influence that she had on me. There was another person who influenced the way, जिस तरह से मैंने cancer को accept किया, was Sanjay Dutt. Same time, Sanjay Dutt मेरे co-star रह चुके हैं. वो lung cancer से battle कर रहे थे. और उनका भी ट्रीटमेंट उसी हॉस्पिटल में हो रहा था. लेकिन क्योंकि कोविड था, मैं उनको सोशल मीडिया पे देख रही थी कि वो तो फिल्म भी शूट कर रहे हैं, उनकी फिल्म भी रिलीज हुई, हिट भी हो गई, और अपने काम पे ऐसे जा रहे हैं जैसे कुछ कोल्ड एंड फ्लू हुआ है. एंड आई वाज लाइक वेरी डाउन. उनको देख के मुझे लगा कि वाई मैं ऐसे ट्रीट नहीं कर रही कैंसर ट्रीटमेंट को. Because cancer treatment is good, and वो 4-5 दिन की दिक्कत होती है कीमो में जब आपके cells बहुत down हो जाते हैं. But besides that, you can continue to lead as normal as you can a life. And he inspired me. So that was the time जब Mr. Anupam Kher ने मुझे फ़ोन किया, क्योंकि मैं travel कर रही थी, mask लगा के airport पे थी. अगले दिन उन्होंने मुझे फ़ोन किया कि तुम फिल्म करोगी, तो मैंने की. And that's how Signature, the film Signature happened. So he influenced me, Dr. Saab.
So these are the voices, the people around you who have a great role to play, and who were the people in your life who had that type of an influence, and then you moved on with the diagnosis and with the treatment?
तब मेरी बेटी बहुत छोटी थी, शी वॉज अबाउट 14, और उसने जैसे आजकल हम सब करते हैं, उसने बहुत गूगल पे रिसर्च किया, एंड शी सेज मामा जो आपको है वो ज़्यादा घबराने की बात नहीं है, एंड उसने और लोगों के ऊपर रिसर्च किया जिन्होंने सेम काइंड ऑफ ट्रीटमेंट लिया था. सो शी रियली हेल्प्ड मी अ लॉट, एंड एज एनी मदर बिकॉज यू आर लिविंग विथ योर डॉटर, आप थोड़ा सा एक ब्रेव फ्रंट प्रिटेंड करते हो, और प्रिटेंड करते करते वो आपकी एक एंगल बन जाता है लाइफ में उस टाइम पे. एंड मैंने अपने पेरेंट्स को नहीं बताया था, हालांकि हम एक ही घर में रहते हैं, बिकॉज मम्मी वॉज अ पार्किंसंस पेशेंट. 2 साल पहले मैंने उनको खोया, तो उस टाइम पे वो बहुत कमज़ोर थी, और मेरे डैड भी 80. तो मैंने कहा उनकी कोई सिचुएशन नहीं आनी चाहिए. तो घर में नर्सेस तो थी बिकॉज मम्मी को अटेंड कर रही थी, तो आई हैड अ लॉट ऑफ हेल्प, उनको पता था, बट मैंने अपने पेरेंट्स को नहीं बताया. मैंने कहा एक बार सब डॉक्टर्स कह रहे हैं कि दिस इज़ ट्रीटेबल, एक बार ट्रीटमेंट ख़त्म हो जाए, लेट मी टेल देम कि कुछ हुआ था और अब ठीक हो गया. तो जब बात कीमो के बाद बाल झड़ने की आई, तो मैंने अपने फादर से ही मुंडन करवाया, बिकॉज आई सेड पापा मेरे बाल बहुत झड़ रहे हैं. तो मेरे डैड एकदम अपने आप को क्लीन शेव रखते हैं, बिकॉज बहुत थोड़े बाल रह गए, सो ही स्टेज बॉल्ड, एंड उनके पास वो बजर था. तो मैंने कहा लॉकडाउन है, कुछ काम वाम हो नहीं रहा, मैं भी सोच रही हूँ एक बार मुंडन करा लूँ. तो ही सेज मैं करता हूँ, मेरे पास सबसे अच्छा बजर है, अभी अभी मैंने एक नया भी मंगाया है. तो उस चक्कर में उनको कुछ डाउट नहीं हुआ, बिकॉज ही थॉट कि मैं सिर्फ बेटर ग्रोथ के लिए मुंडन कर रही हूँ.
फैमिली सपोर्ट.
फैमिली सपोर्ट, यस.
फैमिली इज योर एंकर.
या
नाउ आपने गूगल की बात करी, आपकी बिटिया ने गूगल किया.
बहुत खतरनाक चीज़ है सर.
थैंक यू सो मच.
बहुत खतरनाक.
सो थैंक यू सो मच. अब इस जर्नी में अगर आगे बढ़ें, आपने बात करी डायग्नोसिस की, आपने बात करी ट्रीटमेंट प्लानिंग की या ट्रीटमेंट स्टार्ट होने का. टेल अस अबाउट द emotional and the social impact and the social, not the impact, I would call it as a social battle. How did you win the social battle and the emotional battle? Emotional was what was inside, and the social was what was around you.
Yes, because वो आपको फिजिकली इतना इम्पैक्ट करता है, स्पेशली खासकर जो प्रोफेशन में हूँ उसमें सुंदर दिखना, ये सब बहुत काउंट करता है, एंड वही चीज़ इम्पैक्ट हुई. एंड ये मेरी ज़िंदगी में सेकंड ब्लो था, बिकॉज़ इससे पहले 10-12 साल पहले मेरे को कार एक्सीडेंट में सिर्फ फेस पे ग्लास लगा था, एंड सो एक टाइप का एक्सपीरियंस था, एंड आई जस्ट डिडंट बिलीव आई वाज रीलिविंग दैट. तो मैं अपनी बिल्डिंग में भी किसी को पता नहीं था. तो आई गेस वैनिटी स्पेशली विथ विमेन इज सच अ बिग पार्ट ऑफ आवर लाइव्स. तो मैं हमेशा विग पहन के, कैप पहन के, आईब्रोज नहीं थी तो आईब्रोज बना के, सनग्लासेस इवनिंग तक रखती थी, बिकॉज आई लैशेस भी चले गए थे, नीचे वॉक भी वैसी लेती थी. तो येस, इट्स वेरी डिफ़िकल्ट टू शेयर, बट जब आप शेयर करते हो तो यू विल बी सरप्राइज्ड लोग किस तरह से आपको सपोर्ट करते हैं. एंड ये चीज़ मैंने रियलाइज़ की जब मिस्टर अनुपम खेर ने बोला ये वीडियो मैं अपने सोशल हैंडल पे डाल रहा हूँ, एंड आई वाज लाइक नहीं 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 बिल्कुल नहीं डालना. एंड माय सिस्टर सेड नहीं नहीं डाल दो. उसके बाद जो मुझे कॉल्स आई, जो सपोर्ट मिला, जहाँ जाती हूँ जो ब्लेसिंग्स मिलती हैं, जो सपोर्ट मिलता है, तो इससे मैंने एक चीज़ सीखी है कि प्लीज़ टेक हेल्प एंड प्लीज़ शेयर. इट विल ओनली बी better for you, and your journey will be so much easier.
So does that ease the coping
Yes.
sharing eases the coping?
Yes, it does.
Excellent. Now, what about the emotional?
Sir, emotional तो जाता ही नहीं है.
Mm-hmm. But what you doing, you know, because you had an active public life, you were out in the public, you were shooting, you were doing everything to carry on with the day-to-day activities and to carry this burden of the disease in the background and the side effects of the chemotherapy. How were you coping up with the side effects of the chemotherapy while you were working as well? You know?
Like you can see, ki it is something that stays with you emotionally, but every day is not so bad. It's high and low. किसी दिन आपको लगता है it's okay अगर I get something like this again. I have doctors like this. And we have the best doctors in the world. Our Indian doctors are fabulous. They give you so much of emotional support, which I'm not sure you get so much outside, and they're wonderful. But Dr. Saab, I got lucky. मुझे जो roles मिले ना, उसमें you age a bit. जब आप कीमो लेते हो, obviously बाल वाल नहीं होते, तो मुझे उस टाइप के roles मिले जहाँ पे looking fabulous was not part of the deal. I was playing somebody older. Emergency film आई उसमें भी you know, like I got a minister's role. Signature maybe I was playing a cancer patient. They tweaked the film script. और उस टाइप के mother role, उस टाइप का role मिला. So I was comfortable.
So what special were you doing in terms of your day-to-day activities, your lifestyle, your diet, and your exercise during chemo, which can inspire so many others around the world?
I'll say take it slow. आराम से सब कुछ हो जाएगा. मैं थोड़ी सी अग्रेसिव थी पहले कीमो के बाद भी. वॉक लेना शुरू किया, डाइट में ये वो और पूरी चार्ट बनाई. बट मेरे डॉक्टर ने कहा डोंट वरी महिमा, जो बहुत गरीब होते हैं ना, जिनको डाइट के बारे में कुछ पता ही नहीं, दाल रोटी खाते हैं, वो भी ठीक हो जाते हैं. सो डोंट वरी, जस्ट स्टे हैप्पी. मेंटल स्टेट इज़ मोर इम्पोर्टेंट देन योर डाइट राइट नाउ. एंड आई थिंक वो धीरे धीरे मैंने रिलैक्स किया. एक्सरसाइज भी मैंने कुछ ज़्यादा कर ली. जैसे अभी आपको बता रही थी, हम लोग शूटिंग कर रहे थे, एक दिन ऑफ मुझे मिला, मैंने रूम में पूरे दिन योगा किया, पूरे दिन, यू नो. और इंस्टाग्राम पे देख देख के कि कैसे उल्टा लटकना है, कैसे ये करना है, कैसे वो करना है. मेरे को इतना बॉडी पेन हो गया 3-4 दिन के बाद, बिकॉज इट वॉज सो न्यू एंड आई वॉज सो वीक. आई गेस आई थॉट I needed to get an MRI of the whole body. So take it easy. सब कुछ ठीक हो जाएगा. I would say take it easy on your diet. Take it easy on the exercise.
So is there a magical diet, and were you following one?
I tried to have all that वो जो barley water and all of that. But when you have chemo, it's difficult because there's so much of nausea. So थोड़ा सा भी टुकड़ा आपके मुंह में चला जाए बहुत है.
So now the journey post chemo, there are side effects which are in the short term and there are side effects in the longer term and ongoing side effects of hormonal therapies.
Yes.
What has been your mantra of coping up with the side effects?
कुछ दिन तो बहुत जोश आता है. मतलब जो साइड इफ़ेक्ट्स है हार्मोनल थेरेपी के, वो यही हैं कि बॉडी एक होता है और एक ब्रेन फॉग होता है, नींद नहीं आती और थोड़े मूडी हो जाते हो आप. कभी कभी आप बहुत सोशलाइज करते हो, कभी कभी आप किसी का जवाब भी नहीं देना चाहते, कभी कभी आपको लगता है हर चीज़ ज़िंदगी में कितनी इम्पोर्टेंट है, अच्छी है, कभी कभी आपको समझ में ही नहीं आता, कुछ इम्पोर्टेंट नहीं लगता. So it's a lot and every day you have to focus. उसमें आपको meditation help करता है, where you become very conscious of the present and you try to stay in the present. So I've been doing that to stay away from so many things, and I try and keep myself very busy ताकि मैं थक के रात को सो ही जाऊँ.
So staying busy is important.
Very important. Stay busy.
Find out something to do
Yes.
and not to laze around.
Not to laze around. सच्ची और कुछ काम नहीं होता तो मैं अपने cupboards clean करने लगती हूँ, kitchen clean कर देती हूँ. You know, like I clean the drawers, I throw out things, I declutter.
So does that mean that live life middle of the road, no extremes of anything, diet, exercise or anything, sensible middle of the road living? Is that the message you would like to?
वही मैसेज है, लेकिन जब आप इस ट्रीटमेंट से जाओगे ना, आप मिडिल ऑफ द रोड जा ही नहीं पाओगे. या तो आपकी गाड़ी इधर ऑफ रोड जाएगी या इधर ऑफ रोड जाएगी. सो वही है कि आपको बार बार अपने आप को वो बीच मिडिल रोड में लाना है. या तो किसी दिन आप सोचोगे क्या डाइट वाइट, खा लेते हैं समोसे, खा लेते हैं कचौरी, और क्या किसी दिन आपको लगता है नहीं बिल्कुल ककड़ी पे ही जिंदगी निकालनी है, यू नो, स्प्राउट्स ही खाने. तो आपको वो मिडिल रोड में रहने के लिए इट्स लाइक लर्निंग टू ड्राइव ऑल ओवर अगेन.
So that's a different challenge altogether.
Very challenging.
Right. I think as we are talking about the coping, the side effects and all that, now one very pertinent question is, apart from the treatment and its side effects, is the role of the society in general and the role of awareness. Our women are not aware. And that probably is the reason we are not picking up cases in the early stages. How many women go for an annual or a once in about 12 to 18 months mammography? That's a very small percentage. So about mammography, we hear a lot of things. Women come back and say it's X-ray based, it's detrimental, it's bad for you. So a very strong message from your side, you know, you did it, you picked it.
बिल्कुल बहुत सारे ऐसे आर्टिकल्स मिलेंगे आपको जहाँ पे वो बोलेंगे कि मेमोग्राम इम्पोर्टेंट नहीं है, बट इसने ही मेरी ज़िंदगी बचाई. तो आई थिंक मैं एक बहुत गुड एग्जांपल हूँ जहाँ मैं सिर्फ एवरी 2 years मेमोग्राम करा रही थी आफ्टर 40, एंड उसमें ही पकड़ में आ गया, और इतना छोटा सा था और पकड़ के आ गया. तो आई थिंक ये इम्पोर्टेंट है कि आप हर साल अपना चेकअप कराएं और अपनी सोनोग्राफी ज़रूर कराएं, और अगर 40 के ऊपर हैं तो मेमोग्राम आई थिंक मेरे हिसाब से इम्पोर्टेंट है.
And as we were discussing the other day, you made a mention that after your diagnosis, there was a rush of people around you.
Yes.
Who could be influenced.
Yes.
So one good example could lead to a cascading effect. I think that's something we all humans also look forward to. You know.
Yes, क्योंकि जब वो वीडियो निकला, सब मतलब मेरी लेबोरेटरी जहाँ मैं टेस्ट कराती हूँ, उन्होंने भी फ़ोन करके बोला कि महिमा तुम्हारी वजह से हम लोग कॉन्स्टेंटली बुक्ड हैं. मतलब तुमने इतनी अवेयरनेस क्रिएट कर दी ये बात बोल के कि सालाना चेकअप कराना कितना ज़रूरी है, और लोग सोचते हैं कि खाली ब्लड टेस्ट करा लिया तो टेस्ट हो गया. हम लोग इतनी सेल्फीज़ लेते हैं अपनी रोज़, सब लोग लेते होंगे 10, 20, 100 तो लेते ही होंगे दिन में. एक अपनी बॉडी का सेल्फी लेना, अंदर से क्या हो रहा है वो लेना ज़रूरी है साल में एक बार. आई थिंक इट्स वेरी वेरी इंपॉर्टेंट.
That's a catchy phrase that बॉडी के अंदर की सेल्फी लेना भी बहुत ज़रूरी है.
बहुत ज़रूरी है सर. और एडुकेटेड लोग इस बात को नहीं मानते. मेरे खुद फ्रेंड्स, मेरे डायग्नोसिस के बाद मैंने उनसे पूछा जो मेरे बराबर ही एडुकेटेड हैं, कुछ तो डॉक्टर्स से मैरिड हैं, मतलब कॉन्स्टेंटली दे आर टॉकिंग अबाउट दिस. मैंने उनसे पूछा कि तुमने टेस्ट कराया? नहीं, आई डोंट वांट टू डू, व्हाटएवर इट इज, इट्स ओके, ऐसी ऊपर चली जाऊंगी. तो ये एक अलग कॉन्सेप्ट है जो लोगों के दिमाग में है कि उनको पता लगाना ही नहीं है क्या है. बट आई थिंक जिस दिन किसी ने आपको बोल दिया कि आपके 10 दिन रह गए या 20 दिन रह गए, उस टाइम पे आपको एहसास होगा कि काश मेरे पास कुछ वक्त और होता बच्चों के साथ, फैमिली के साथ, लाइफ के साथ. दैट्स द टाइम यू विल अंडरस्टैंड. आई नो सबको डर लगता है कि कुछ निकल तो नहीं जाए, बट इट्स बेटर जल्दी पता चले, वो इम्पोर्टेंट है. आज हम चर्चा इसीलिए कर रहे हैं कि अगर कुछ होना है तो जल्दी पता चल जाए आपको, तो आपका ट्रीटमेंट फटाफट हो जाएगा, और नहीं है तो नहीं है, टेस्ट कराने से थोड़ी आ जाएगा अगर नहीं है तो।
So that's a strong word कि टेस्ट करवाने से बीमारी नहीं आएगी,
नहीं आएगी,
यदि होगी शरीर में तो पाई जाएगी
बस।
So you came out very strongly about your disease, about your treatment. A lot of people don't come forward. That is immensely appreciated because that has catalyzed many people to look after their health and their
Yes.
bodies, you know.
Yes.
What was the motivation, you know? What made you tell the public at large that well, this is a disease, and I can say that on your behalf, that this is a disease detected early can be conquered?
I think it was the people around me who helped me share this. मेरे co-stars, और उन्होंने ही मतलब ये बहुत beautifully actually put forward किया. They helped me out.
Excellent. I think that's amazing, you know. And the how much is the positivity angle, जिसको हम हिंदी में कहते हैं कि सकारात्मक रहिए किसी भी सिचुएशन में.
मुझे बिल्कुल पता नहीं था कि कैंसर से रिलेटेड इतने सारे ऑर्गेनाइजेशंस हैं, इतने सारे सपोर्ट ग्रुप्स हैं, और मतलब देयर इज़ अ होल कम्युनिटी देयर टू सपोर्ट यू. मुझे बिल्कुल आइडिया नहीं था. जब मेरा ट्रीटमेंट चल रहा था तब लॉकडाउन भी चल रहा था, कोविड बहुत ज़ोर से चल रहा था, तो एक अकेलापन भी था. अब जब दुनिया खुली है तो अब जब लोग मुझे इनवाइट करते हैं, और हर एक स्टेट में, हर एक डिस्ट्रिक्ट में, अलग अलग लेवल्स पे, डॉक्टर्स के लेवल पे, डॉक्टर साहब जैसे आप ये इवेंट्स कर रहे हैं, अवेयरनेस क्रिएट कर रहे हैं, इस तरह से कितने सारे ऑर्गेनाइजेशंस हैं जो कैंसर रिलेटेड हैं. आई थिंक देयर इज़ अ लॉट ऑफ सपोर्ट आउट देयर. तो कभी भी किसी को डिटेक्ट होता है, डोंट फील अलोन. यू आर नॉट अलोन. ये फीलिंग होना बहुत ज़रूरी है.
So once the treatment happens, there is life after treatment, after disease. So what's your take on that? Now it's been a couple of years. Beyond that, so how do you motivate people?
सर अलग अलग मूड, कभी कभी लगता है हाय यार मेरे को क्यों हो गया, इन लोगों को देखो, ये लोग रात भर सोते नहीं है, इतना गंदा खाना खाते हैं, एक्सरसाइज नहीं करते, इनको नहीं हुआ मुझे हो गया. और कभी कभी लगता है अब हो गया ना कैंसर, अब क्या हो जाएगा, अब विल फाइट व्हाटएवर इज कमिंग ऑल्सो. सो इट डिपेंड्स ऑन व्हाट मूड यू आर इन. पर अब ज़िंदगी थोड़ी और प्रेशियस लगती है. अब लगता है कि बहुत लोग कैसे अपनी लाइफ को इम्पोर्टेंस नहीं देते, अपनी हेल्थ को इम्पोर्टेंस क्यों नहीं देते. अब ज़्यादा समझ में आता है कि देयर सो मच द बॉडी नीड्स. बॉडी को बहुत वक्त चाहिए हीलिंग के लिए, रिकूपरेट करने के लिए. हम लोग यंग होते हैं तो सोचते हैं कि नहीं करियर बना लें, बट डोंट डू इट एट द कॉस्ट ऑफ योर बॉडी. सोना, स्लीप, 8 hours ऑफ स्लीप, अच्छा खाना खाना, सोशलाइज करना, ये सब बहुत इम्पोर्टेंट चीज़ें हैं, यू नो.
Excellent. I think
थोड़ा हम लोगों को भी बात करने दो.
sir,
You seem smitten by her, so let us talk to her also.
sir करेंगे, सब करेंगे.
No, you don't seem
So कभी आपको ये कभी एहसास हुआ या कभी ये फीलिंग आई, why me?
आती है सर, अभी भी आती है, क्योंकि मेरी फैमिली को किसी को डिटेक्ट नहीं हुआ ब्रेस्ट कैंसर या फिर कोई भी कैंसर.
Did you feel that there was something missing in the lifestyle or in the way you were living that could have been the trigger or could have been the cause for all this?
I couldn't think of anything, but
So just a sporadic. The message
I think
is
too much stress था 4-5 साल से. So I think sometimes लोग बोलते हैं ना, stress is the biggest killer. So stress manifests itself in different kinds of diseases. Some people may get high blood pressure, some people may get diabetes, किसी और को कोई और प्रॉब्लम हो जाएगी, शायद स्ट्रेस was one of the reasons I got this.
So I think we in this conversation, we have a couple of comments, very quick comments or questions महिमा जी के लिए, but please बड़ा संक्षिप्त रखिएगा.
बिल्कुल.
क्योंकि
बिल्कुल. मैं इन्होंने तो मेरे एक सवाल का, मैं जर्नलिस्ट हूँ, सवाल सोच के आता हूँ, इन्होंने एक सवाल को किल कर दिया. मैं इनको कहना चाह रहा था, सवाल पूछना था कि खुले बालों में आप बड़ी सुंदर लग रही हैं, ये रियल है, लेकिन उसका तो आपने राज खोल दिया. तो मेरा इम्प्रेशन केवल सुन लीजिए ब्रीफली, एक लाइन में, कि अगर कैंसर उतना भी बुरा रोग नहीं है, क्योंकि आपको देख के आप इतनी सुंदर लग रही हैं, आप अपने प्राइम ऑफ लाइफ से भी ज्यादा सुंदर लग रही हैं.
क्या बात है सर, थैंक यू, आपने यू मेड माय डे.
Thank you. So
thank you so much.
So any other please, any other question, comment? I think in the interest of time, Yashika, please.
Hi Mahima ma'am, thank you so much for coming here.
Bring the mic closer.
Yeah, so I'm also currently dealing with this disease, and I'm currently battling stage 4 TNBC, triple negative breast cancer. I think there's been an assumption in the society that, you know, if somebody is diagnosed with such a disease, the person can't continue living a normal life. In a lot of employments, we have seen this challenge that when we are trying to get a new job or when we disclose our disease, people just assume that the person won't be able to do justice to this job or the role.
That's a great question. Yashika, you brought a very pertinent issue to the fore.
And I've been following the celebrities. Hina Khan is the latest example. She's been going to work, doing anything that a normal person would do. So what message would you like to give to the society who just assume that, okay, if somebody has a cancer, that person can't do anything?
Thank you so much.
There are so many cancer survivors. People don't survive a heart attack, but they survive cancer. And there's so much of treatment today that मैंने खुद देखा है. जब मैं ट्रीटमेंट ले रही थी, बहुत लोग अपना कीमो लेते थे, खुद गाड़ी चला के वर्क पे जाते थे. मुझे बहुत अच्छा लगा. एंड आई थिंक वो जो कंपनीज हैं जो अपने स्टाफ को, जो कोई भी डिजीज बैटल कर रहे हैं, उनसे कंटिन्यू रखते हैं या ऐसे लोगों को हायर करते हैं, दे आर गोइंग टू गेट something which they may not get from any other regular employee, and that is loyalty and a lot of gratitude and blessings. ये आपको सिर्फ भगवान दे सकता है, besides somebody who's fighting a disease. So this is a message to all the companies.
Thank you.
जो कैंसर पेशेंट होता है वो काम पे जाता है, नॉर्मल लाइफ जीना चाहता है, लेकिन लोग क्यों नहीं उसको सोचते हैं कि वो नॉर्मल लाइफ जिए. जनरली ये माना जाता है कि कैंसर पेशेंट है, वो जहाँ काम कर रहा है, तो बहुत लोग ऐसा देखते हैं, अरे ये मेहनत नहीं कर पाएगा, ये भाग दौड़ नहीं कर पाएगा. मैं इसको फील कर रहा हूँ, इसलिए पूछा. आपसे चाहता हूँ आप अपील करिए.
नहीं, मैं खुद बताना चाहती हूँ कि ऐसा कोई डिफरेंस नहीं है. मतलब जब आप ट्रीटमेंट ले रहे हैं, आपने ये सोचा हुआ है कि मैं नहीं कर पाऊंगा, बट एक्चुअली खाली 4 दिन जब आपका कीमो होता है या रेडिएशन होता है, जो भी ट्रीटमेंट होता है, साइकिल्स होते हैं एवरी 21 डेज, उस टाइम पे 4-5 दिन आपको रेस्ट की ज़रूरत होती है. बाकी आप नॉर्मल ज़िंदगी जी सकते हैं. आई थिंक मोस्ट कैंसर ट्रीटमेंट्स टुडे और बेटर हो गए जब से मैंने लिया है, एंड उसमें आप रेगुलर लाइफ जी सकते हैं.
But did you, in your own sphere, feel any change in the workplace attitudes or their perceptions?
मेरे वर्क प्लेस में मुझे बहुत 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 वार्मथ मिली. जिन्होंने भी मेरी इंडस्ट्री में इसके बारे में सुना, सब ने जो उनकी मेरे लायक रोल हो सकता था, जो पहले शायद उन्होंने नहीं सोचा होगा, बल्कि उस टाइम पे उन्होंने फ़ोन करके बोला कि आपको ये फिल्म करनी चाहिए. और अभी भी मेरी एक और फिल्म आ रही है, वो इट इज़ अबाउट सेकंड इनिंग्स दुर्लभ प्रसाद की दूसरी शादी, तो ये भी मेरी सेकंड इनिंग्स है एंड वो फिल्म भी अबाउट सेकंड इनिंग्स है, तो आप लोग ज़रूर देखिएगा. कुछ लोग तो कंफ्यूज हो गए, मतलब इतना वायरल हो गया वो फिल्म का वीडियो, ज़्यादातर लोगों ने सोचा शायद सचमुच शादी हो गई, तो और इससे लोग बहुत होपफुल भी हुए. बहुत लोगों ने सोचा हम भी दूसरी शादी के बारे में सोच रहे हैं, हमारी भी ऐसी मतलब जिंदगी रंगीन हो जाएगी. तो एक बहुत खुशी का माहौल क्रिएट हो गया, जिन्होंने भी ये वीडियो देखा, मेरा और संजय मिश्रा जी का. आप खुद सोच रहे थे कि मेरी शादी हो गई.
So there is one
Taking
comment.
the question forward, what sir has said, what was the society perspective with respect to the treatment when you were taking and now? What is the difference that you have feel?
What is the
society perspective with respect to the time when you were being diagnosed to the present scenario where you are? Can you just share that perspective in a
I
briefly?
think मैं ज़्यादा क्रेडिट नहीं लूँगी, बट थोड़ा सा क्रेडिट लूँगी कि मेरे स्टोरी शेयर करने के बाद आई थिंक एक एक्सेप्टेंस जो पहले थोड़ा कम था विथ कैंसर, एंड आई थिंक बहुत सारे हमारे फिल्म एक्टर्स जैसे सोनाली और संजय दत्त एंड हीना, हम जिस तरह से काम करे जा रहे हैं और लगे हुए हैं, और एक आप लोगों को अंडरस्टैंडिंग, सभी ऑडियंस को अंडरस्टैंडिंग आई है कि हाँ कैंसर हुआ था और अब ये वापस जॉब पे हैं और काम कर रहे हैं. इससे बहुत फ़र्क पड़ा है लोगों की अंडरस्टैंडिंग ऑफ द डिजीज़, ऑफ द आफ्टरमाथ, and how one can continue. I think बहुत affect हुआ है.
So that's a strong message that the disease or the treatment should not slow you or should not stop you, as Yashika very rightly said.
Absolutely, Yashika.
Yashika,
you should continue.
Thank you so much.
And whoever you're working with, whoever gives you a job, I think is a great organization.
I think one last comment or a question, and in the interest of time, we'll have to
Hi ma'am,
close.
I'm also a survivor, okay, and I have two sons, one is 12 and one is 8. So they still don't know that what I have gone through. So you also have a daughter, so I just want one suggestion, how you can tell your kids about this thing that.
Have you finished your treatment?
Yeah, everything is done.
I think उनको थोड़ा बड़ा होने दो, अभी उनको अंडरस्टैंडिंग भी नहीं होगी.
Yeah, I know. That's
हाँ,
why
तो जैसे ही वो बड़े होंगे, और आजकल के बच्चे तो बहुत जल्दी बड़े हो रहे हैं.
They're very smart. I mean,
yeah.
I hate Google because my son always Google it, and he was like, "Mama, I mean, why you shaved your hairs and all those stuff about the."
I think you should wait.
Yeah.
कोई आपको एडवाइस जरूर करेगा कि आप फटाफट बता दो,
Yeah.
but मैं कहूँगी आप you can wait.
Thank you so much.
Thank you so much. Ladies and gentlemen, let's give a standing ovation to Mahima Chaudhary ji for gracing the occasion, for talking to us about her life story, for inspiring all of us, and so many others who are on the social media platform. And before we close the session, I have the honor of inviting Professor Rakesh Kumar and Dr. Sabhyata to honor our guest. So honor our esteemed guest. So as I said, Professor Rakesh Kumar is the spirit behind all this. Thank you so much.
I was just telling her that she was an inspiration to many of us earlier, but now she is inspiration to all of us, everyone in the world. Thank you, ma'am, for coming.
Thank you so much. Thank you, Ji. Any last word you would?
थैंक यू सो मच डॉक्टर साहब, आपने मुझे यहाँ बुलाया, और आई होप बहुत सारे लोग जो अभी कैंसर ट्रीटमेंट ले रहे हैं, मैं उनको हिम्मत देना चाहूँगी और यही बोलना चाहूँगी कि आप स्वस्थ हो जाएं और हिम्मत रखें और भरोसा रखें। जितना आप अच्छा सोचेंगे उतना ज़्यादा आप जल्दी ठीक हो पाएंगे। और बाकी लोगों को यही कहना चाहूँगी कि आप अपना सालाना चेकअप ज़रूर कराएं और घबराएं नहीं। चेकअप करा के आपको संतुष्टता होगी पूरे साल के लिए कि मैं बिल्कुल स्वस्थ हूँ। और टेक केयर ऑफ़ योर हेल्थ एंड गुड लक एंड हैव अ वंडरफुल लाइफ।
चाहे पत्नी हो या बेटे हो, वो भी अपनी अपने घर की महिला को चेकअप के लिए वो आगे करेंगे। अगर वो इसमें लापरवाही तो फैमिली के बाकी मेंबर्स कहेंगे कि आप लोग उसका चेकअप करें।
So now we will announce the oral for. Yeah. So now we will announce the winner for oral, and we have Dr. Aarti Kumawat. Dr. Aarti Kumawat. And for e-posters, we have both Dr. Siddharth Arora and Dr. Tansi Daljit. Okay, so we will announce that we are providing certificates and the amount will be 15,000 for Dr. Aarti Kumawat, and for e-posters, Dr. Siddharth Arora. So for next, for e-poster, Dr. Siddharth Arora and Dr. Tansi Daljit. May I request them to come on the stage? Okay. So we are going to provide them e-certificates and the amount will be 10,000 for both.